Your life.
Okay. A very good evening to one and all of you to our ARC webinar on PG Update series on cornea. We are lucky to start off this webinar with an amazingly strong expert panel. We are lucky to have our President AIOS, Dr. Mahipal Sachdev, to be joining soon, who has led us through these trying times with his phenomenal leadership. We are honored to have with us Dr. Namrata Sharma, Honorary Secretary AIOS, who has again led us most ably through these tiresome times with a very well laid out, immensely educative webinars and has further enhanced AIOS leadership. We have with us our esteemed Professor Dr. Titiyal, heading the Cataract, Cornea and Refractive Department at RP Center, New Delhi, an academician and surgeon par excellence. We have with us Dr. Rajesh Sinha, Honorary Treasurer and man of great potential, a major strength of AIOS. We have with us Dr. Sudhir, leading the Cornea Department of Shankar Nethralaya with his prolific academic and surgical prowess. We have with us Dr. Somshila Murthy, a torchbearer of LVPI, leading the Cataract, Cornea and Uvea Department therein, and also, of course, the member scientific committee. I'm truly lucky to moderate this webinar with a brilliant genius, Dr. Rajesh Fogla, an internationally reputed cornea surgeon, a teacher par excellence, with superb skill sets to foray into not just cornea, but multiple subspecialties of ophthalmology. And he is going to challenge us to think beyond in the next couple of hours. We shall start this interesting webinar with our first speaker. Has Dr. Radhika joined in? Dr. Radhika has not joined in. Probably Mr. Sunil, can you contact Radhika in the interim? Would you be ready to take on Dr. Revati?
Okay. Yes, yes, I can start.
Yeah, we have our, we are just changing our schedule for a bit. We have a speaker, Dr. Revati, to detail us on the topic penetrating keratoplasty, the essentials. She is the Chief of Cornea and Refractive Services of Arvind Eye Care Systems, Coimbatore, has over 50 publications, has authored book chapters, and is a strong presence in national and international forums and a teacher of great value. We look forward to hearing from you, Dr. Revati.
Thank you, Chitra. Hi, good evening, all of you. And thank you, ARC and Dr. Chitra, for giving this opportunity. It's apt to start this session with the penetrating keratoplasty. Am I audible?
Yeah.
Yeah. Because this is a full thickness corneal transplant. But actually, historically, if you see, it replaced the lamellar surgeries, which started earlier because of its superior optical results. But it also has some of the significant weakness. For example, it's an open globe procedure. I don't think the present generation of ophthalmic surgeons are familiar with the problems of open globe procedure. And it also leaves behind a very weak scar, which can open up even after many years. And graft rejection is a major problem, and also the suture problems. So considering all these things nowadays, with better understanding of anatomy and also better instrumentation, again, the trend is towards the lamellar procedures with a better globe integrity. But still, we need this procedure in some of the conditions. For example, a full thickness scar, especially in the visual axis, or if it distorts the cornea too much to cause visual problem. And also combined dystrophies like macular dystrophy, which can involve even up to the endothelium, and Fuchs dystrophy sometimes can present, corneal ectasia can present with the Fuchs dystrophy, and long-standing bullous keratopathy can result in stromal scarring, significant scarring. Then keratoconus after a bout of acute eye drops can leave behind a nasty scar, which then we need full thickness grafting, and also regrafts. For example, the graft here, a grossly decentered regraft, a graft which if we are going to do only an endothelial keratoplasty, the optical results will not be good. So you need a well-centered central penetrating keratoplasty here as a regraft. So this is a lifelong commitment between the patient as well as the surgeon for the graft to survive for a long time. So before going into the surgery, we have to assess the prognostic factors. One for graft survival, other for visual potential. Both can be different because, for example, a corneal pathology, a leukoma in the visual axis can have a better graft survival prognosis. But if that scar presence starts at the age of 1 or 2 for the patient, then the associating amblyopia is going to affect your visual potency. So that we have to keep in mind before advising surgery. And also the comorbidities, if it is on an already operated eye or with other ocular problems or systemic problem. So to assess the risk factor, if for a graft to survive well, you need a wet ocular surface, a non-inflamed and intact ocular surface without any symblepharon or scarring. The lid should be normal, and more importantly, the limbal stem cell barrier should be healthy. And the corneal pathology ideally should be a one-time pathology like a scar, or a non-inflamed pathology like a dystrophy without any vessels. And if it is a recurrent problem like a viral keratitis, then again it's going to be reducing its survival chances. And even a first-time graft can have better survival potential than a regraft. And also the rest of the anterior segment, the anterior chamber as well as iris lens diaphragm should be intact anatomically. That is very important. And also your posterior segment. Coming to the donor factors has little role in graft survival. Once you select a good fresh donor donor material, the age of the donor actually plays very little role for the graft survival. Coming to the preoperative evaluation, you have to keep in mind all these things to evaluate the patient. And also very importantly, your torchlight examination, especially to look for the visual potential. Often you cannot do refraction or other things, so you have to look for phoria, tropia, fixation, and pupillary reaction if possible. Sometimes you may need you have to go for visual evoke potential. And you have to assess the anterior ocular surface as well as cornea in the slit lamp, and also the anterior chamber, especially if there is a pseudophakia, if there is a lens. It should not be mobile like this, it should be out, and ideally either natural or synthetic lens should be behind the pupil and with a round pupil. That is an ideal situation. And of course, you can use the imaging techniques whenever necessary to assess the posterior segment as well as the glaucoma part of the examination. Coming to the preoperative preparation, you have to restore the ocular surface and control the inflammation and the intraocular pressure. And if it is a recurrent pathology like herpetic scar, you have to start the prophylaxis, appropriate prophylaxis. And the anesthesia, you need, this is an open globe procedure, again I warn you. So you need a complete akinesia, lasting anesthesia for a longer time, and reliable control over IOP and BP. So if you can achieve these things, either with regional or monitored intravenous or general anesthesia, as per your preference, you can go for it. And the speculum should not give any pressure over the globe. And whenever the scleral rigidity is compromised, you can go for scleral rings to avoid the collapse. And then you have to mark the cornea as a first step. The graft should be centered to the pupil always. You have to remember that, and mark the pupillary center. And you can mark these radial marks for aiding to aid in your suturing. And the trifines, the host cornea will be trifined, that is a circular rotatory movement. And this will be done either with a handheld trifine or with the hand-free vacuum trifines, which are more sophisticated to give better results. And first you have to choose the graft size. So mark and see, that depends on your host pathology as well as the corneal size. Ideally, it should be between 7 to 8 mm. You have trifines in 0.25 steps, so you can choose the correct size. And of course, with the femtosecond, you can even the shape of the graft also can be changed. Coming to the donor cornea, you are going to punch the donor cornea, not refine the donor cornea. So the donor cornea, we punch from the endothelial side so that the endothelial damage will be minimal. And also you get a little larger endothelial surface with more endothelial cells. So the punching, again, you have to go choose 0.5 millimeter more. Normally, it can be between 0.25 to 0.75 because a little oversized graft will give a better contour as well as it will avoid trabecular collapse to prevent secondary glaucoma. Coming to a small video, this is an older video, sorry for the quality. It may not be, the instruments also may not be very sophisticated, as you can see here. First, we mark the donor size, we selected. So we are going for a 7.5 millimeter trifine to punch the donor cornea. So once you punch, then you take 7 millimeter trephine to do the trephining movement on the donor recipient. We will not enter with the trephine directly up to 3/4 or 80 to 90% will go. Then enter the anterior chamber and fill it with the viscoelastic and gradually open it, so that sudden opening of the anterior chamber will be avoided. And then all the extra tags should be trimmed and removed, so that the sides should be vertical and regular. These extra tags can cause irregular astigmatism. Then the graft is sutured. First 4 cardinal sutures, because I always use the interrupted sutures. So go for 4 cardinal sutures, one in 12, 6, 3 and 9 o'clock position. The depth should be almost around 90% of the donor as well as recipient cornea. And arm should be equal on both sides, and the tightness of the suture should be ideal. Like it should not be too tight or too loose, just proper approximation. And after putting, and each suture should be followed by the diagonally opposite suture, so that uniform tension will be maintained in the cornea while suturing. So after putting these 4 cardinal sutures, you are dividing this corneal circumference as into 4 quadrants. So each quadrant will be filled with 3 sutures, as you can see here. Then after completing the sutures, trim the edges, and the knot should be buried onto the donor side, so that to keep them away as much as possible from the limbus, to avoid any vascularization and later rejection. So the suture, we have to remember the 4 cardinal sutures and the depth and the uniform tightness. It can be interrupted, or it can be running suture or double running, or a combined interrupted and running also. The interrupted sutures are ideal when there is a disparity between host cornea and the peripheral, the donor cornea. And later also you can manipulate each suture separately. If there is a loosening or vascularization, you want to manipulate the astigmatism, it's easy. But running suture is a more elegant one. But the problem is, if one suture get cut somewhere, the whole suture has to come out. The post-operative care, usually antibiotics till only the epithelium heals. The steroid has to be gradually tapered over 3 to 6 months time, and maintained as with a minimum of around one time to minimum of 1 year, or sometimes we try to keep them lifelong. And the cycloplegic hypotensives as and when required. And the main important thing, lifelong follow-up and the patient education to recognize early signs of rejection and come to you as soon as possible. And post-op each examination time, you have to carefully look at each suture for vascularization, loosening, signs of rejection, edema, rejection lines, and intraocular pressure, the fundus and refraction. Each time you have to do all this examination. And the suture removal usually starts after, I prefer to go after 1 year to up to 2 years. We can gradually remove the sutures, or sometimes we can keep them on as long as possible till you get a nice good scar like this. And if there is loosening or breaking or vascularization, you have to remove the sutures. And after each suture removal, remember, you have to hide the steroids, because suture removal itself can precipitate graft rejection. And in high risk cases, we can also add topical cyclosporine or tacrolimus. And in viral keratitis scars, you have to continue the oral antiviral therapy for at least a year. Complications, intraoperative, as I said, it's an open globe procedure, so you can end up with any dreaded complication. So proper planning can avoid all these things. Still, the suprachoroidal hemorrhage or expensive hemorrhage can catch you, even an experienced surgeon, suddenly. So you have to be well prepared for that. And post-operatively, in the early period, a poor donor selection can go for primary failure, or a persistent epithelial defect, a wound leak, or endophthalmitis is another dreaded problem. The late complications, I am like mainly the microbial infections associated with sutures has to be managed as microbial infection. Recurrence, you can expect in viral etiology, and glaucoma has to be managed with your glaucoma colleague. The other 2 problems are going to be dealt, because they are very important. They are going to be dealt separately later in the session. The glaucoma, better you have a good relationship with your glaucoma colleagues, because many times some of the drugs what they use as prostaglandin analogs or CA inhibitors may be detrimental for your graft. So you have to really have a lot of dialogue with them to manage the glaucoma in these grafts. And there's a very short literature review. This is some of the registry studies where they analyzed thousands of cases to come up with what we have seen already. What are the risk factors and the good things for predictors for graft survival. And in conclusion, this is still needed and relevant procedure in some conditions. So all of you should learn it as you are learning SACS or something in cataract. And you can get excellent results with proper planning, patient selection, and a lifelong partnership with your patient is very, very important to have very long success for this grafting. Thank you.
That was a very crisp, detailed talk, Dr. Revati. Dr. Rajesh, would you want to start? I might have a question or two to ask too.
And that was a very nice review of a broad topic like penetrating keratoplasty. Dr. Revati, the question that I have is, in the current era where lamellar keratoplasty, both anterior and posterior, seem to be quite popular, what are the common indications for penetrating keratoplasty in your clinical practice?
Yes, Dr. Rajesh, as I said, some full thickness microbial keratitis leaving behind up to the endothelium scarring, very nasty scarring. Even keratoconus post eye drops, many times we'll be able to do the DALK unless you have such a very bad scar. And we sometimes come across keratoconus with guttata. So we don't know. I really hesitate to go for only DALK in those patients. But I have done in one patient only endothelial keratoplasty for PKP and later DALK also. So maybe you can do, even such cases, you can go for lamellar keratoplasties, but maybe in experienced hands. And these are the main things, indications, I would say. Even in ICE, you can go for endothelial keratoplasty unless it's really bad anterior chamber.
Dr. Namrata, are you there online?
Yes. Yeah, I am very much there.
What are the recent advances in penetrating keratoplasty? You had a recent publication on the role of intraoperative OCT during penetrating keratoplasty. So how has it changed?
So intraoperative OCT is a very useful tool for cases of penetrating keratoplasty, and is very relevant to country like ours, because all said and done, we may talk about lamellar keratoplasties, but 70% of the cases that undergo keratoplasty in our country, as per the Eye Bank Association of India statistics, are still full thickness corneal transplants. That too for reasons of either healed keratitis or for active corneal ulcer. Intraoperative OCT helps in these kind of cases because most of the cases may be, adherent leukomas or corneoiretic scars. So you actually know, looking at the intraoperative OCT, where is the iris and whether it is touching the back of the cornea or not, what kind of synechia are there, are they filiform or are they broad-based, and how should you trephine so that you don't, damage the iris and the iris gets spared. So in those kind of cases, it really helps, especially helps in children because children are very difficult to examine. So in those cases, in pediatric keratoplasty, they are extremely useful. Otherwise also, they help you, intraoperative OCT microscope helps you to see what you actually cannot see through a operating microscope otherwise.
I have one question. Would you treat an eye which has neurotrophy? Apparently, the ocular surface looks stable. Would you let the patient be with ambulatory vision, or would you want to intervene in these kind of cases?
It's a very nice question, Chitra. Like I forgot to mention that I really hesitate to touch a neurotrophic cornea if the cornea is anesthetic. And Dr. MS also often used to teach us. Sometimes you come across corneas after a very beautiful graft, after some time, for no reason, it will start melting. So these are neurotrophic corneas. And if, as you said, if the patient is having some ambulatory vision, I would prefer not to touch, especially penetrating keratoplasty. No. Maybe if it is endothelial problem, endothelial graft, it's okay. Like I won't touch it for a penetrating keratoplasty.
Your thoughts, Dr. Titiyal? Dr. Titiyar?
Yeah, good evening.
Yeah.
I think once you have a neurotrophic element in the cornea, it's mainly the anterior part of cornea which gets involved with the dryness or opacities. All these cases do very poorly with any sort of keratoplasty, maybe a lamellar or a full thickness. As you rightly pointed out, if patient has some ambulatory vision, it's better to delay the surgery in these cases. But in those cases where you have no other option, where you have to do surgery only, so maybe our first attempt should be to do a penetrating keratoplasty if the opacity is full thickness. If it is a anterior corneal opacity only, I would go for a, at least 7.5 millimeter lamellar keratoplasty in these cases. Then preserve the ocular surface as far as possible. Treat anything which is going to come immediately. So these cases on table, sometimes you might go for a tarsorrhaphy, which will give you some sort of management of ocular surface in these cases. Or people also have gone for putting an AMG graft in a very, very severe cases. If you have not done these two things, you observe your patient the first few weeks, how the patient goes. Accordingly, you can manage subsequently. So these patients are very high risk for a graft melting, as Revati had nicely told us. So you have to be very careful a posterior period when you are bombarding with the topical medication, especially steroids. You should be a little careful there. In a little bit of doubt, you must think of decreasing the palpebral size or give some sort of some cover with the AMG so that it doesn't melt out. And some people do put a contact lens also immediate post-op. That might help you regaining the ocular surface faster. But these cases are also very highly prone for infections also. So you have to be a little careful. And sutures also, whatever suture you put on table, they behave differently in these cases with the ocular surface disease. Very careful. Every time you see your patient, must stain ocular surface with the fluorescent dye. See what is the suture pattern, tight, loose suture that can be picked up by a fluorescent examination, and you can replace them or redo them. And any infiltration which is coming, infiltration in suture should be taken seriously in these cases because that can be infective.
I have one more question. It's a case, if it were a case of a unilateral blindness of cornea and is very much vascularized, would you still decide to do a PK with immunosuppression? Would you want to do a K-Pro, or would you not like to do anything at all?
I think that situation, let me answer Revati, then you can take it over. Sorry, I was online.
Yes, sir. Carry on, sir, please.
So these one-eyed patients, and with such a vascularized corneal opacities, if you have a little window, sometimes you do have a little peripheral chunk available. The simple optical iridectomy or managing the pupil can help in these cases also. Even you get some ambulatory vision, which may be 460, 560, even we have achieved 618 sometimes also. That would do it. So that should be the first consideration for these patients. If you have no other area for making a pupilloplasty or something like that, then if you have to think of surgery, I would definitely give a chance for a penetrating graft in these cases. See how these patients behave. It is a primary surgery. Immunosuppression may not be required to begin with. But if fails and you have to do resurgery, yes, you have to keep them on immunosuppression for a long, long time. Even second surgery failed, then the option would be a K-Pro in these cases. So because one-eyed, I'll avoid K-Pro because life of K-Pro also is not very prolonged. So that you have to look into consideration. Yes, Revati, all for you.
Yes, sir. You covered everything, sir. Of course, same answer.
I think one more thing that generally is asked is, when would you have a sizing more than 0.5 millimeter? When would you have a oversized graft? So oversized is basically used for pediatric grafts, for therapeutic keratoplasties, and for corneoaradic scar. So this is one common question which is asked to the postgraduates. And the second is that in cases of fungal keratitis, invariably they'll ask after therapeutic keratoplasty, when do you start steroids? So the answer is after 2 weeks, after 2 weeks or after epithelial. I think you have a talk on that.
I
Then
think
maybe it can be. Okay.
Dr. Rajesh, more questions?
Just one question. Dr. Revati did mention about the antiviral prophylaxis. Maybe I can ask Dr. Somshila regarding if you have a vascularized corneal scar of herpetic etiology, what kind of post-operative antiviral prophylaxis do you give? What dosage and what duration?
Yeah, thanks, Dr. Fogel. I think you read my mind. I was just about to, although Dr. Titian has covered just about everything, but just the small point about when you do keratoplasty for viral etiology. So preoperatively, we do start the patient on antivirals and make sure that you have a quiescent period, as well as continue the same post-operatively. So I think Dr. Revathi just mentioned that briefly. But Dr. Revathi, I had a counter question for you. So since everybody's discussed that the indications, although 70% are there for penetrating keratoplasty, but most of the time these are the very tough and challenging kind of indications. And even if it's for an optical reason, then it's usually a vascularized graft. So do you use any intraoperative adjuncts like intraoperative subconj, bevacizumab, or post-operative eye drops? So I'm just asking that in the context of we have studied this more than once with subconjunctival injection as well as post-operative topical medication of the same bevacizumab, and we've had fairly good results. But of course, we also put the patient on preoperative immunomodulators.
Yeah, then we don't know which one acted. Actually, even I too prefer to, as a preoperative preparation, to give subconj Avastin or something, at least 2 or 3 times to see whether any regression. But generally, my observation, once these vessels, they establish very little regression of these vessels. And of course, in such cases, going for a systemic immunomodulator will be more ideal. Of course, no harm in trying these things because I don't think they are going to give any great side effects or anything.
Oh, but
I like to use the fine needle diathermy, what Dr. Harminder Dua has described, especially in cases where there are deep stromal vascularization. And I find that in addition to whatever topical therapies immunomodulators you are starting, the fine needle diathermy also helps reduce the vascularization, and subsequently when you do a full thickness graft, it tends to give a better outcome.
I have one more question. If it's a triple procedure, what would be the tips you all would suggest to avoid on-table complications?
So I think Revathi will answer that.
Yeah.
You mean the like associated cataract extraction?
Yeah.
Some of my students used to do, like if it is not a very bad cornea, they do a SCCS or a phaco first and then go for the grafting separately. I don't know, but it's rarely, I have not tried that. Like as I said, gradual opening of the anterior chamber. And once you open, go for the lens removal, but generally getting a rhexis will be very difficult. So plan for a sulcus fixated IOL, a three piece, something like that. As soon as you put the IOL in, and all these steps should be very fast. And sometimes you can use mannitol before, like if it is really like needed. Other than that, I don't take any other precaution, but of course, calculating the IOL power could be a challenging problem in these cases.
One thing I would like to add here, and that is that when you're doing a triple procedure, many times when you remove the lens fibers, what happens that there is the posterior capsule becomes like a dome if there is a lot of positive pressure from the vitreous side. So in such cases, even implanting the IOL becomes very difficult. So preoperatively, we have to take precautions in order to reduce the pressure, have a good hypotony. But if at all that is happening, then in that case, we may put initial cardinal sutures and then inject high viscosity viscoelastic to flatten the capsule and then implant the IOL. So that is something that sometimes we have to do.
Yes, Dr. Rajesh, it's a very important tip. Yes.
Yeah.
Also, aspirating the cortex, you should remember, as Rajesh pointed out, it will be like a dome instead of a convex surface, posterior surface, the posterior capsule. So when they are aspirating the cortex, they should not go deep. Like generally we go deep like this, but you have to be very careful. You have to keep it in the same plane, your movement of your IA.
Dr. Sudhir, you had something to tell?
I think in all cases of penetrating keratoplasty, it's better to have a Fleringa ring for safety. I think when it is highly vascularized, and in case of triple procedures, it gives you more safety. I think that is one thing which we need to look into it.
Good. And one other question I asked, I'm sure the answer is fairly obvious, but if a patient has a PK, would you prefer to do the glaucoma management before the graft surgery, or would you sometimes do it after?
You mean the glaucoma surgery?
Yeah, the patient has a glaucoma issue too.
If it is a PK, I would like to have the glaucoma surgery before.
Always before, I think.
Maybe EK, like, injecting air and keeping it, not for people like Rajesh and experienced surgeons, but others it might be a problem. But for PK, it's always better you control the IOP with even surgery and then go for it.
Dr. Rajesh, any more question, or do we go on to the next speaker?
Can I make a quick comment,
Yes.
Dr. Chitra?
Yeah.
The quick comment is that contrary to conventional teaching, where probably when we were doing our fellowships, that whenever the patient has a cataract, it was told, or whenever the patient is in the 50s or 60s, to do a triple procedure. I think that now we can divide the two into two separate surgeries. Go ahead and do if we have to do a PK, go ahead and do that first. And the cataract can be addressed at a separate sitting, because with the modern phaco, we don't have to worry really much about endothelial cell loss. We get a much better result, both refractive as well as surgical technique wise.
Yeah, you can calculate the IOL power better also, definitely.
Dr. Rajesh, anything to add?
One of the other things that you can do, there are two Rajesh here. So when you mention Rajesh, it refers to Rajesh Shina and
Resume
myself.
surname. Both of them, are in attention position the moment you say that.
Yeah, both of us, become attentive and we unmute ourselves.
No, we have to respond. So basically we can't. So Dr. Rajesh Shina, please go ahead.
Okay. So what did you ask, Chitra? Can you?
I said, do you have any more questions to ask before we move on to the
No, one thing.
They are not attentive at all.
They both are thinking the question is for the other one.
No, one thing I would like to add here is that see, based on head study, the prophylaxis for viral keratitis induced scar when you do a PK is for 1 year. That's what is the general practice. But these days things are changing, and a lot of people are using acyclovir for as long as possible, and you just keep doing the liver function and the renal function test done. So this is something which is changing now.
So we shall go on to our next speaker, Dr. Bhupesh Bagga, who's going to be enlarging on special considerations in therapeutic keratoplasty. He's a consultant cornea, cataract, and children's eye care at LVPI, actively involved in teaching and research activities with clinical interest in infectious keratitis, corneal lamellar procedures, and cataract surgeries. Look forward to hear from you, Dr. Bhupesh.
Hello, am I audible?
Yeah.
Hello.
Yes, you can be a bit loud.
Good evening, all. Good evening, all.
Yeah.
Screen is visible?
Yeah, it's visible.
Yeah. Good evening, all, and thanks, Dr. Chitra, for the opportunity. So in this evening, I am going to discuss some consideration about therapeutic keratoplasty, and Dr. Revati has almost covered the basic principles and of the keratoplasty, and discussion was around about the keratoplasty and some about the basic principles of keratoplasty. So my talk will be basically to deal with the indications, pre-operative preparation of the therapeutic keratoplasty or TPK, intraoperative measures, post-operative care, its complications, and their management. Regarding the indications, in contrast to optical keratoplasty, the major indication for therapeutic keratoplasty is worsening infection, basically to control or eradicate the infection. Or other way, this is also performed for tectonic when the infection is either consolidated, but there's a lot of thinning or descemet or large thinning or impending or large corneal perforation where you cannot provide tectonic support by application of any of the means like tenons or tissue adhesive or multilayer AMG, then we have to perform keratoplasty in those conditions or advanced corneal thinning. Like this patient of fungal keratitis worsened in spite of using possible antifungals and proceeded for therapeutic keratoplasty. Similarly, like this patient of gram-negative bacilli pseudomonas keratitis presented with thinning of almost 90%, but later on follow-up presented with a large perforation and proceeded for the therapeutic keratoplasty. In the preoperative preparation, which is very, very important to understand in particularly therapeutic keratoplasty, that you have to make a rapport with the patient and also with the staff. So taking care of anxiety of the patient by discussing about the goals and actually discussing about entire procedure makes actually life very easy during that 1.5 hour, 2 hours sometimes of that procedure. So I believe this is the most important part of the surgery in the preoperative preparation. Then we have to select the anesthesia, reduction of intraocular pressure as we were discussing for optical keratoplasty as well, the selection of donor, selection of instruments, particularly few instruments like trephine size, use of vitrectomy, which is usually not available very commonly in corneal OR, but we need to be prepared and inform our sister or staff prior to the starting of surgery. So regarding the history, we need to be very cognizant about the disease duration, prior treatment, because that actually changes entire way how we are going to proceed with the surgery, compliance of the patient, history of use of corticosteroids, use of anti-glaucoma medications, like any other surgery as covered by Dr. Revathi, diabetes mellitus, hypertension, cardiac disease, because that is going to affect our surgery as well as surgical outcome. Patient's age, general condition. Also, we need to understand, can the patient comprehend or consent about? He should be very clear that this surgery is particularly for eradication of infection or tectonic support, not to give vision. Basically, we may need multiple surgeries to understand that this surgery is to eradicate the infection, not to provide vision, and to have to go for multiple other surgeries to get the vision back. And this may land up into recurrence of infection as well. In complete examination, like in any other surgery, we have to check completely PLPR, other eye status, adnexal, like ectropion, entropion, because we have to take care of these things prior or side by side of surgeries. We cannot delay the surgery because of ectropion or entropion in many cases. So we have to take care of by doing some adjuvant procedures. So coming to preoperative evaluation of the cornea, which is very, very important. The slit lamp examination before starting the surgery is very, very utmost important, that to measure the size of infiltrate, measure the thinning of the infiltrate, look for extreme or where the actually thinning is there. If possible, perform the OCT as well, site of actual perforation, scleral involvement, limbal involvement, also along with need to see the peripheral anterior chamber, the lens involvement, iris exudates, intraocular pressure, and posterior segment involvement, because it actually changes the entire procedure and how we going to approach with this case. Donor selection actually is very important, particularly when using large graft. We tend to take intact epithelium graft because of epithelialization issue develop in these large therapeutic keratoplasty tissues. It should be very good quality tissue, if possible, compact or clear stroma is actually good to have a better view of anterior chamber details during the procedure, and also to look for any recurrence, anterior chamber recurrence as well. But if there is urgent or some need of transplantation, we can use suboptimal tissue based on the availability with proper explanation to the patient. Anesthesia, usually we prefer to give our local anesthesia in most of the cases, and it works well. But important thing is that if your cornea is very thin, you need to be very carefully give a block. Like I have seen this in video, you're giving graded block, and also with proper explanation, with proper discussing with the patient, some graded 2 to 2.5 milliliter, and then weight, and then little bit of massage, without application of pinky or without application of massage, much of massage, and then little bit of more anesthetic agent, so that it should not be like a problem or perforation on during the block. Many a times facial block along with the periorbital block actually works very well. But in cases of pediatric patients or patients who are having some very large perforation or one eye, it's a very uncooperative patient, GA also is one of the very important anesthesia. Pre-op mannitol, as we were discussing before, is preferable in most of the cases, particularly in cases where having corneal perforation or long-standing perforation where you have seen that iris lens diaphragm is actually coming anteriorly, or you are basically thinking that this surgery is going to prolong. If there is no risk factor like cardiac issue or kidney failure, is always advisable to give pre-op mannitol, and it's always good to have half an hour to 45 minutes prior surgery, because this is the best effect you will get in that time. Always ask your patient to go for white before starting the surgery. Coming to surgical procedure proper, you have to have a proper exposure without putting a lot of pressure on the globe. So after putting the mannitol, you either use wire speculum or lid suture. Flaring actually saves almost every case. This I use for almost every cases, if possible. If you're not finding the involvement or your globe is really nice to have that support, flaring ring actually gives a lot of support, particularly in cases where you have like corneal thinning or impending perforation, or having high myopia or actually having perforation. So conjunctival peritomy is very important, where you are having a suspicious of sclera involvement or limbus involvement. It needs to be done. Hemostasis to be achieved by wet-fed cautery or use of thrombin, or I use nowadays alpha-gun drops prior to the surgery. It actually helps. Better to avoid as much as possible to use of cautery, use all these other measures. So coming to a few steps of the surgery, few videos like this. I have tend to take unedited videos to show the real problems. Like this patient was having flaring, I applied Fleringa ring, and the importance of Fleringa ring actually that gives us a lot of support to the globe. It should be well placed and equiplaced like this. Second thing is, in this case, as you can see here, the exudate is only 6 to 7 millimeter, but is not able to define the margin. So we have to take, first of all, the AC exudate out to actually get the clear margin. So making a side port where you are not finding any infiltrate, clean area to mark your side port, and then with the use of saline and then followed by visco, take out this exudate, and you can see that now you are able to see the well-defined infiltrate. So this is basically the advantage of taking out the exudate out. This case was having almost limbus to limbus involvement, with not very sure that how much is the exudate and how much is the infiltrate, but on slit lamp it was looking like a almost limbus involvement. So not able to get removal of this exudate by the side port. As you can see, while trephination and while removal of the button, all the exudates came out. This is a very important step to make I make two PIs, sometimes 3 PIs if you are, because many a times, because of inflammatory exudates, actually fibrin blocks those PIs and causes the pupil to block. This is the case of acanthamoeba keratitis with long-standing treatment. Many times we see in these cases a sort of pannus is coming, or sort of fibrin covering the entire cornea. We have to clean all that pannus from the limbus, and I'm using a thrombin powder to control the bleeding. Then making measurements around that after the peritomy. And after that, the steps are as the previous case. So this was almost, you can see that sclera is almost looks like involved, a lot of cheesy material, and it's a long-standing untreated fungal keratitis. So first of all, they have to refine the base. Removal of the conjunctiva, you can see all the conjunctiva is so cheesy, you're not able to find out the actual extension of the infiltrate. So a lot of bleeding was there. So I applied sponge soaked with adrenaline, and it actually worked well. After that, actually bleeding stops. And then I could see that there was not much of scleral extension. I could get 13.5 millimeter trephine. But for the donor, I needed little larger, 14.5 or 15 millimeter. So that was not there. So in this, I tried to first remove the anterior part of the exudates because I was not sure about the anterior chamber and I'm not sure about the lens as well. So first removal of the anterior part and followed by removal of the posterior part with very, very guarded entry in the cornea and the anterior chamber. And then you can see that later on, things are so clear. Lens was also not involved. You can see the feeling looks like the healthy sclera. We made a 2 PI followed by application of hand refined button of 15 millimeter. And then later on, same steps as I reposed this conjunctiva as well. Later on. This was a central perforation with anterior iris and lens is coming anteriorly. So this was basically a tricky case, although trephine is almost 8 to 8.5 millimeter, but the condition was like it was almost anteriorly placed. So side port was not made, partially thickness definition was done, and then slowly with guarded entry with the use of visco, entry was made and then the button was excised. So this was a case of pythium keratitis where actually patient was lost to follow up and came around 7:30 evening. You can see the lens was actually coming out with almost hardly any rim of the cornea. So it took the patient, this was a patient of 17-year-old under general anesthesia, and decided we cannot save the lens, so decided to proceed with the surgery and starting with the removal of anterior capsule with the help of anterior vitrectomy probe, and then removal of all the exudates, and then cleaning of all the exudates along with the lot of bleeding was there. So I was not very careful, but could not put the ring because of eye was almost like collapsing. And after that, removal of the rim, and then putting almost 12.5 millimeter cornea. So this patient did very well. This is a 2.5 month follow-up of that patient with a vision of best corrected around 20/60. So could save the eye and could save the patient as well. So this is a patient of acanthamoeba keratitis. You can see the limbus is also involved, the sclera is involved. But the good thing is in acanthamoeba, many a time the sclera is actually having involvement, which is like not of very infective. So this patient actually underwent, I performed DAL. Basically, I was thinking to go for PK, but could achieve good, nice big bubble and proceeded, and took a lot of time, but actually proceeded very well. So all the steps as we know as a traditional DALC. And then this is the follow-up of that patient. This is again a patient of acanthamoeba keratitis where the central cornea was almost 90% thinning. So proceeded with the simpler procedure, same procedure of DALC, tried in that patient, in that case 9 to 9.5 millimeter trephine.
Bhupesh, can you summarize? We are short of time. We have another 5 more speakers.
Yeah, so I'm finishing, sir. Yeah, so there's few complications which we need to think about. So this is like acute in early stage complication, like this patient developed hyphema. This patient of fungal keratitis was thinking that looks like a recurrence or residual infection came out with a lot of posterior stromal haze. On follow-up, cornea started getting clear, and that later on repeat graft, it worked very well. So this is the patient problems with the large graft when we are not sure about the that use the graft host junction. Lot of overrides are there and lot of exposure. And this happens when we are not taking care of that part. Particularly in these cases, torsorrhaphy or along with amniotic membrane is recommended. This nobody wants that is a recurrence or of infection. So this actually infection resolved with cryo and other things, but the eye could not be saved. This patient was fortunate that we could save the eye with the use of infiltration B wash. This is the case of DM detachment after therapeutic keratoplasty, which later resolved along with cataract surgery. The outcome was good. This is the recurrence of fungus infection, which was actually anterior, not only anterior stomal, but also posterior stomal, which was confirmed by confocal microscopy. This was the histopathology of that. So there's a late complications which we see in other same grafting like rejection, and this is the failed graft over the keratoplasty was done. Thank you very much.
Thank you very much, Dr. Bhupesh, for a very elaborate talk. Dr. Rajesh, would you ask a question? Dr. Rajesh? Rajesh Fogla. Okay.
Yeah. One of the questions that we come across is that when, are you able to hear me? Or
yeah,
it's still...
now we can, yes.
Yeah, if you remove a cataract during therapeutic keratoplasty, so do you consider implanting an IOL, or would you do that at a later date?
No, this should not. In therapeutic keratoplasty, we should not put any IOL and try to preserve the lens as well, unless until it is popping out or having ZD or having a full mature cataract where you are having a difficulty in forming the anterior chamber. So there's a big no to implant any IOL.
If there is a recurrence of infection in your graft, how early would you intervene surgically, or would you initially manage conservatively only?
So if the size of the graft is, if the size of recurrence is like very small, as I showed in that particular patient, so it's always good to try wash, or it's coming from the anterior chamber. If the host is involved, then it's nice. Then the involvement is like you're not able to control with medical therapy. It's good idea to take a little larger graft, particularly to cover that particular area. So in those cases, early surgical treatment is always recommended as compared to waiting for medical management. But if you're from an anterior chamber and localized, then you can try cryo, or you can try amphotericin B wash in anterior chamber with amphotericin B or voriconazole wash.
Bhupesh, coming back to the lens management once again, often in therapeutic keratoplasty, you find that at the end of surgery, it's quite difficult to form the anterior chamber, which remains shallow. And post-operatively, you sometimes have secondary glaucoma. So if you remove the cataract, sometimes you can form the chamber well. And also in fungal infections, often you find exudates that are sticking to the posterior surface of the iris. So what are your pointers in terms of managing this situation?
So this is basically a case-to-case change in the plan. If you are finding that your anterior capsule or exudates are going behind the iris, I think in those conditions, and you are seeing the yellow glow, and there's no point in then saving the lens, and better to take out all the whatever the exudates and anterior capsule and even the bag as well, and also perform the limited vitrectomy, and with the help of your retina colleague, go for, if possible, go for vitrectomy as well as intravitreal amphotericin B or voriconazole as well. But if your case is like a not very much limited, and you're just not able to form the chamber, I think is not a good idea, because chamber usually forms with time if you are not having that much bulge intraoperative. So with my experience, that if your iris is not that much involved, exudates are not going behind, try to preserve the lens, because if your lens is actually involved, lens you have taken out, and also you ruptured the posterior capsule during the manipulation, actually it complicates the procedure, number one. Number two, if you perform the cataract surgery or you take out the lens, the posterior capsule many times stuck with the posterior part of the iris, and you're actually not able to perform secondary IOL in those conditions. So it's always safer if you can preserve the lens, provided you are very sure that you are not leaving the infection behind.
I think in such cases also, if you have graft host disparity of more than 0.5 millimeter, like you make it 0.75 or 1 millimeter, then also it kind of helps to form your peripheral angle and your anterior chamber. So that also can be used as one of the tricks or tips, whatever.
Is there a role for limited, vitrectomy, like through a single port, just doing a little bit of core vitrectomy to reduce the upthrust, so thereby you can prevent the spontaneous expulsion of the lens? Any of the panelists would like to comment on that?
Yes, I have done it in a few cases, and in triple procedures also. Actually, I have done it with a 25 gauge vitrector and a little bit of limited vitrectomy, so that the capsule falls back, and that helps in managing. So even in therapeutic grafts, therapeutic keratoplasty, this works quite well, and I have done it personally, and it helps.
Therapeutic grafts, the only problem is that these cases are already infected. So I don't know whether you would still want to do a limited anterior vitrectomy first, and just to decrease the pressure. But for optical grafts, I think it does make a lot of sense.
Just sometimes just doing a vitreous tap also helps in forming the AC at the end of the case.
Yeah, actually with a 23 or 25 gauge vitrector, it's like a vitreous tap only.
Yeah.
It helps without causing any traction in the vitreous, we can remove a little bit of vitreous, and that helps. Another thing, at the end of the procedure, it is always better to inject intracameral antibiotics. So that will also be useful. And one more point I would like to add here is that Dr. Bhupesh has very nicely pointed out that GA, general anesthesia, is preferred, and then graded local anesthesia, which he used, we have been doing it very often. The third thing that of late I started doing was subtenon block. And subtenon block is very useful in such cases because you just have to inject about 3 ml. It doesn't increase the pressure of the globe, and it works quite well. So you have a good echinacea even with a 3 ml block, and it is very effective.
Yeah, I think thanks, Dr. Rajesh. This was a very important point. With many times long surgery, we tend to give like subtenon, and actually it works very well. And the use of Xylocard intraoperative actually helped in many cases in these particular things.
Maybe we should go on to our, yes, Namrata.
Having said this, I would still think, and we also, I think 90% of the cases are doing under general anesthesia.
Yeah, that is obviously preferred.
The challenge we have is the anesthetists don't see the same way that we do, that all cases need general anesthesia.
We have a very privileged anesthetist with us. Dr. Rajesh Sinha's better half is an anesthetist, so we don't have a problem.
Just a point about the lens management. Bhupesh, excellent talk, and you covered pretty much all the points. And I think that you've emphasized very well that even if the anterior chamber doesn't form at the end of surgery, so one tip is for us, we'll get a retina colleague. We don't have Rajesh Sinha with us, but I think we can also learn quickly to do the single port vitrectomy limited. That is one easy way. And also, as Bhupesh may just agree that sometimes you observe these cases, give postoperative mannitol and lower the pressure, and the anterior chamber will form. So sparing the lens and not having the lens out is very important, I think, in these cases.
Thank you. I think we'll go on to our next speaker because we might run out of time. Our next speaker is Dr. Shirish Kumar, who is going to be dwelling on the topic DALK, Advantages and Steps of the Surgery. He's a medical superintendent of Eye Foundation Group of Hospitals based at Coimbatore, senior consultant in cataract, cornea, and refractive surgeries with 21 years of teaching experience, with innumerable presentations nationally and internationally, good number of publications and textbook chapters, and a very prolific surgeon. I request, Shirish, you have to limit to your 15 minutes because we would definitely intervene. All the speakers ahead, because I think discussions are very critical.
Okay. Thank you, Dr. Chitra, and thank you for the wonderful opportunity. So my topic is deep anterior lamellar keratoplasty, advantages and surgical technique. As we all know, DALK is a surgical procedure that selectively removes pathological corneal stromal tissue down to Descemet's membrane, followed by transplantation of a donor graft without DM and endothelial layer. So for the most part, the procedure is an extraocular procedure, and it's a non-open sky procedure. It's less invasive than PK, and it avoids some of the dreaded complications like expulsive hemorrhage, or the chances of endophthalmitis is less. As you see in PKP, which is much more common because it's an open sky procedure, and the rejection chances are less as the host DM endothelial layer is retained. So the endothelial cell loss is minimal, or it's negligible. If you are not entering into the antechamber, the cell loss may not be there at all, and less postoperative complications as we can remove sutures early in the postoperative period, and steroids can be stopped 5 to 6 months after the surgery. So most of the complications are associated with the steroid usage and because of the presence of sutures. So this can be limited, or you can reduce these complications. And donor tissue need not be A grade. I am just showing this picture just to show that this particular patient is a young patient, but we have transplanted an elderly cornea, which is around 80 years of age, old donor. So you can see the ARC here. If it is cosmetically acceptable to the patient, we can always go ahead and use these B-grade corneas for DALK. And visual recovery is fast. This is a few of my own cases. The first day postoperative picture, you can see the clarity, the cornea on day 1. Coming to the surgical procedure, the surgical procedure involves stromal trephination, stromal dissection, separation, donor preparation, and suturing of the donor tissue to the host. And trephination, it can be a vacuum trephine, or it can be a handheld or a manual trephination. So vacuum trephination is more predictable with less chances of perforation. However, the perforation chances are more common in handheld trephines. And for optimal outcomes, reaching Descemet's membrane is desirable, and the main concern going as deep as possible is the increased risk of perforation. Various techniques of stromal separation has been described by various surgeons. However, the fastest and the easiest way to reach Descemet is the big bubble technique described by Anwar and Chekman. Just showing a few case examples. This is a case of keratoconus. I'm just showing, demonstrating a big bubble type 1. So it's a well circumscribed and up to 8.5 millimeters in diameter, has a white edge. So this is a type 1 big bubble. And it may happen in one go, or sometimes you may have to inject at different sites. This is the case where I'm injecting at 2 sites to accomplish big bubble. So we have a nice big bubble here. And coming to the surgical procedure, this is another case, a very old video. The clarity may not be great, but it's an interesting video. It's just an observation after the surgery. It was not intentional. This particular patient is macular dystrophy patient. Could see one bubble forming now, and now the second bubble. There are 2 bubbles here. This is a type 3 bubble where you have type 1 as well as type 3 bubble, type 2 bubble. And this particular patient, I could dissect till Descemet's. I thought I have reached Descemet's, but I could see one more layer here. This is the Duas layer. It's actually not necessary to separate Duas layer. It will not affect your BCVA. So once you remove Duas layer, the chances of perforation increases. So it's better to avoid dissecting the Duas layers. Very thin layer, but if you remove it, it makes the Descemet's more fragile, and the chances of perforation increases many folds. Coming to the procedure, once you achieve a big bubble, I usually do a superficial keratectomy to debulk the cornea using a crescent blade and lymph forceps, and I use a 11 number blade to make a nick incision, and I inject a viscoelastic substance through this nick incision to keep Descemet's away from all the manipulations. Then I use a venous scissor and lymph forceps to dissect the posterior stroma, divide them into 4 quadrants or more number of segments, and each segment is completely excised, then taking care not to leave any posterior lip, and finally the viscoelastic substance is completely washed out, and donor preparation, donors Descemet's and endothelial complex was then peeled off from the donor tissue, and I place it on the host bed and suture it using 10 monofilament nylon. I use interrupted sutures. And coming to suturing technique, Dr. Revati has explained in detail the suturing procedure for penetrating keratoplasty. It is something different from penetrating keratoplasty. I usually look for this rhomboidal configuration that gives us the idea about the correct tightness of the sutures, and I usually place 16 sutures if the graft size is more than 8 millimeters. If it is less than 8 millimeters, I place 12 sutures, and these sutures are buried. I usually bury it on the host side, not on the graft side, on the host side. So like sometimes you may not get all the steps right. So this is a case, I'm just showing so I have achieved big bubble and I'm doing a superficial lamellar keratectomy. And brave slash was attempted. I could not collapse the bubble. I go ahead and do some more dissection of the cornea. And now you can go ahead and collapse the bubble. So you may have to deviate from your regular technique depending on the situation. Here is another case. So I inject air bubble, but there's no big bubble. It's actually emphysema of the cornea. Then you go ahead and do a superficial lamellar keratectomy and attempt big bubble after the lamellar keratectomy. So I could achieve a nice big bubble, but I'm not brave enough to make a neck incision, so I could not collapse the bubble. I go ahead with layer by layer dissection. So if you're not brave enough to collapse the bubble in the center, you can go layer by layer and collapse the bubble in the periphery. So you can avoid all the complications which are associated with the perforation of the Descemet's in the center. And once this is done, it's easy. Now I can collapse the bubble in the periphery. Yes, then inject viscoelastic substance and separate, divide the posterior layer to reach Descemet's. Coming to DALK in healed eye drops, this was discussed in the previous talk, the first talk. So this particular patient had a BCV of 6/36. There is a paracentral scar, which is a healed eye drop scar. So we can safely go ahead with the DALK in these cases. This is the OCT, anterior segment OCT picture, and this is patient's SPM values and the topography. If you follow all the steps, we should go ahead and do a manual dissection in these cases. Don't try for any big bubble technique. I am injecting the air superficially, avoiding the central area, perforated area. And this is just to create emphysema so that my dissection is easy. Go layer by layer and be careful in the center where there is a perforation, and leave some amount of tissue there. Sorry. These bubbles, multiple bubbles, give us a rough guide. They act like a rough guide so that you should not go very deep. DALK is any day preferred over PK in these challenging cases. If the scar is paracentral, if it is right in the center, it's better to go ahead with the PK. So this is the first day post-operative picture, and this is 6 weeks and 6 months post-operative picture of the same patient. And this is the preoperative OCT and post-operative OCT. There is some amount of tissue here, some amount of hairs, but the patient has improved significantly. And coming to the complications of DALK, it can be intraoperative or post-operative. Not going into the details of all the complications. Perforation is one of the commonest complications. There are various other complications which are typical of DALK. I'm not going to discuss these complications. This is a case of granular dystrophy. It was a soft eyes, vitrectomized eye, and so the air enters into the anterior chamber. You just change the direction of the needle and inject air bubble into the stroma, create emphysema, and do a manual dissection. There is a very small perforation, and while doing the dissection, there is some more, one more perforation here, but my dissection is almost complete. I can always go ahead and complete my DALK. This is a very old video of mine, almost 10 years old, and it's doing a manual dissection, and there is a sudden perforation in the center. So it's right in the center, but most of my dissection is complete. Again, I went ahead with the DALK. I was not sure about the outcome because this was my first case with a very large perforation, but I continued with the DALK. But to my surprise, the post-operative results was very good. This is the same patient after 1 year. You can see a scar here as a perforation site, slightly below the pupillary margin, and the patient did very well, and the visual acuity has improved significantly. And there are various cases with micro perforations, small perforations. All these patients do very well. And we published this, and the outcome of deep anterior lamellar keratoplasty patients with intraoperative DM tear, DM perforation. And so the results were actually excellent, gratifying. Fortunately, the postoperative prognosis when these presentations, perforations are successfully managed, it does not deviate from the expected prognosis in uncomplicated cases.
You will have to conclude, Dr. Shreesh.
Just a few slides. And this is another case I have shown. There's a perforation. There's a fragile DM. I have removed Duas layer. You just see it's such a fragile DM. We have to convert it into PK. Another case of it's a case of large central perforation I'm demonstrating. Yeah. And this particular patient had a healed hydrops while dissecting the central cornea. I had a large perforation right in the center. I had a Descemet as the Descemet was so protruding. I thought I can, there was a perforation. I thought I can insinuate this spatula and separate this posterior lamella, posterior layer, but in that process I tuned this protruding DM. So this has to be converted because my dissection is incomplete. And the last few slides on DALK in corneal ulcers, that is therapeutic DALK. Therapeutic DALK, of course, we know TPK is normally reserved for very severe and progressive infections that are non-responsive to medical treatment, but it has its own disadvantages, and therapeutic DALK has been reported to be beneficial in selected cases of fungal, bacterial, acanthamoeba, and other types of keratitis, which is not involved the posterior stroma or which has not reached Descemet's or anterior chamber. And you can go ahead and this is actually a picture showing therapeutic penetrating keratoplasty first day and T-DALK first day. You can see the TPK actually shows highly inflamed eye with exudates in AC, whereas T-DALK, that is therapeutic DALK, the eye is very quiet, and it can be big bubble technique. We can do a big bubble technique if the infiltrate is not very deep, and we can do a manual layer by layer dissection if it is very deep. This is a big bubble technique, is a type 2 bubble, and one should be very careful. If you get a type 2 bubble, the chances of perforation is very high.
Have to conclude, Dr. Srish.
So the complications of therapeutic DALK is retention of infection in deep stroma, recurrence of infection, again perforation and interface opacification. So to conclude, DALK is an excellent technique which gives excellent results if we select our candidates and follow proper techniques carefully. Thank you very much.
That was a wonderful, wonderful talk, Shrish. Very well covered, as our previous speakers have also done great justice. You could stop sharing. I have one question to ask. Dr. Titiyal is there? Not there. Dr. Namrata, then. Would you suggest DALK in acute head drops? Because he was mentioning about old head drops.
Sir is also there. I think Sir can. Yes.
Yes. Dr. Titiyal?
Please.
DALK in acute head drops, sir.
Head drop.
I think few people are, doing a DALK in acute high drops also, where I've shown a good results. I've seen results from Dr. Ritu Arora from GNEC Delhi. Maybe a good concept if you get the patient early enough, where you don't have a lot of corneal edema in these cases. It depends how big is the rupture in the Descemet's membrane. If it's too big a rupture, then it may not be possible. Sometimes you have a case where they have a small rupture and big edema. In such cases, DALK is a very good option in these cases. But if you have larger, multiple ruptures, then it's better to wait, treat patient medically, then go subsequently, as nicely shown in the video. That can be contemplated, what Sirius has nicely shown. And we have also seen, if you do a layer by layer DALK in these cases, the central opacity might shift to periphery, and you still get a very good outcome in these cases with the heel hydrops. And you can plan better also. The acute hydros, I think if you have a smaller rupture in Descemet's, you have to assess with intersegment OCT, then plan surgery in these cases.
Dr. Rajesh Fogla, questions?
Yeah, I think Shirish did a nice job showing a lot of videos, and he has shown several complications where you can end up with a perforation and the need to convert to a penetrating keratoplasty. Would like to have the panelists share some tips, what they do to avoid perforations while doing a DALK. Do you do any modification in your case selection, or do you modify the surgical technique for certain situations so that you can avoid having a large perforation and the need to convert to a penetrating keratoplasty? Dr. Namrata, please.
Yeah. So I think case selection is extremely important, because if the corneas are going to be very thin, then you cannot do a big bubble DALK. Maybe Rajesh Fogla can, but then chances that you may have perforation would be much more. Of course, we do DALK in these thin cases only, in corneas which are thin only, and one has to be very careful when you're putting the needle, or you're injecting the air bubble. Then it should be from an area which is preferably not the thinned out area, and it should be somewhere paracentral, and the best guide is that it should be at the place where the pupillary edge is. So that is the best guide. So there you can put the needle and can form a big bubble. Again, when you are doing dissection, one has to be very careful that you don't cause a perforation. Sometimes what happens is, even when you are dissecting the stromal layers, you might cause a perforation, and then you're even while suturing, at times you may take the suture through the Descemet's membrane. So at all steps, DALC is something which is only when it is finished then you say it is done, because it can get tricky, and there can be perforations at any step. Having said this, there may be 2, 3, 4 micro perforations, and you may still go ahead and complete the case, because wherever the perforation is, you start from the other side, do a layer by layer dissection, leave a little bit of stroma there. So that is one way of obviating these sites where perforation is there. I don't know about acute hydrops. I just, sir said, I have a feeling in acute hydrops, there is actually no need to do DALC. And I mean, I can't stop myself from saying that, but I have not personally done it, but I do not understand the logic behind it, or the need to do it early, when one can, wait, see how it goes about, a scar is formed, and then, later on do a DALC, because I don't think you really stand to gain anything by doing an immediate DALC.
Yes, often when the hydrops resolves, the cornea can sometimes flatten, and the patient can experience an improvement in the visual acuity, which may obviate the need for any kind of corneal surgery. What about post-operative stromal rejection after DALC? How common is it, and what kind of steps do you take to prevent that? Shirish, in your practice, you have done so many DALCs, so have you come across stromal rejection?
Yeah, I have come across one case of stromal rejection, and this particular patient had a loose suture, and this particular patient was actually a case of VKC. As a young patient, 21 years, he was a case of VKC, but towards the end, the VKC subsided, but he had the habit of rubbing his eyes, and he had a loose suture for some time, and he didn't realize it, and there was vascularization, stromal opacification, and that has led to stromal rejection, but we could reverse it with the steroids, topical steroids. Early steroids has helped him, and not started him on systemic steroids in these cases.
Dr. Titiar, any points you would like to make on this?
I think Dr. Namrata has reported some of our cases with stromal rejection in lamellar keratoplasties. The best part, as Sirish nicely mentioned, the treatment in these cases are very, very successful. That means recovery is almost 100% in these cases, unlike endothelial rejections. If you treat these patients early enough, normally these patients come early also because they have a good visual acuity. The slightest change in the visual acuity, they'll come back to you. Treatment is quite effective in these cases, and till date, we have not seen a second rejection happening in these cases, which is quite common with the endothelial rejections. So these two are unique in lamellar rejections. They are rare. Normally, maybe a vascularization may be the cause, and treatment is very effective. And the best way to judge these patients are to see these patients effectively by doing anterior thickness. Slightly change the corneal thickness may point towards a stromal rejections. And classically, they are also seen, they start with the one particular area, and slowly they spread to the central area, the edema. So if you have a edema which is located to one particular area of a stroma, you might think that may be a rejection, and that should be an initial clue also in these cases.
I think we go on to our next speaker. Our next speaker is Dr. Paras Mehta. She's going to be talking on DSEC, donor preparation and insertion technique. Dr. Paras is one of the leading cornea surgeons from Gujarat and is a medical director of Sameep Eye Hospital and Cornea Center, with her expertise in her field, a high volume work with special interest in corneal lamellar surgeries, ocular surface, and a lot more. On to you, Dr. Paras.
Okay. Yeah. 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 Are you able to see my screen?
Yeah.
Yeah. Good evening, everyone. And at the outset, I would like to thank Team ARC and especially Dr. Chitra for giving me this opportunity to be part of this PG teaching program.
It is cut from the side.
Sure. Shall I?
And it has to be slideshow, and there's some gray. I don't know. I see a gray patch.
Is this all right? Is this all right now?
No. There's a gray
It's
patch.
not all right.
It is not.
Maybe go to the next slide. Maybe that strip will not be there in the next slide, because I saw your videos initially.
Yeah.
Yeah, it's in the.
Do you still see the same?
No, it's okay.
Ma'am, can you stop share for a minute?
Stop share and then start sharing again.
Okay.
Can you just do the optimize once if it solves? Otherwise, just come back and just click on the screen share once and optimize the second box. Just check once.
Optimize. Okay. Yeah.
Now do it, please.
Yes.
Oh, you share your screen?
Yeah, that's what I'm doing. Sorry, can I go to the first slide?
अभी भी थोड़ा सा ऊपर में ग्रे लाइन आ रहा है.
No, let it be.
Shall I do it once more?
No.
No. Okay.
I think it's there.
Now I'm not able to advance my slides, it seems.
Just click on the screen. You should be able to.
Yes. Yeah. So good evening, everyone. And at the outset, I would like to thank Team ARC and Dr. Chitra for giving me this opportunity. I will be talking to you on the subject Descemet donor preparation and insertion techniques. We all know that penetrating keratoplasty has been there for more than a century, and the limitations which were very well highlighted by previous speakers like wound adhesion, suture-related problems, high immunogenic load, astigmatism, and delayed visual recovery, etc., led to innovations towards component keratoplasty or lamellar corneal surgical procedures. As you can see here, these procedures, the posterior lamellar procedures, are very well accepted now, or people transition from full thickness corneal transplants to lamellar procedures just because it is revolutionary. One can work through a closed chamber and without having, any weakness of the sustained trauma, but also to the surface wet. Many other advantages of that. So if we look at the history, in 1998, Dutch ophthalmologist Dr. Mellis described sutureless posterior lamellar keratoplasty. From there on, in 2001, Dr. Terry and Osley described modified technique, and they called it as deep lamellar endothelial keratoplasty, wherein even the posterior part of the recipient's stroma was also to be removed while implanting a donor lenticule, which gradually transitioned based on the experience to Descemet, that is Descemet stripping endothelial keratoplasty, or we can call it as DSAEK, where it is the donor lenticule is prepared on an automated on the trephines and with a microkeratome on automated mechanism. So it is known as Descemet stripping automated endothelial keratoplasty. And then on, the search went on, and we have moved on even to DMAC. So Descemet stripping endothelial keratoplasty essentially replaces diseased endothelial tissue with a thin donor graft comprising of posterior corneal stroma and Descemet's membrane endothelial complex, as you can see here. The advantages are these patients would have very fast visual recovery, unlike penetrating keratoplasty or full thickness grafts. The topography of the cornea is minimally changed or hardly changed at all. There are no suture-related problems. It is much more anatomical, and chances of immune rejection are less as compared to full-thickness penetrating keratoplasty, as epithelium and majority of the stroma is not implanted. But it has certain downsides, like it has a learning curve. The initial endothelial cell loss, which was reported, was much higher, but with better understanding of the development of newer techniques, probably we have come across that limitation as well. Even donor disc dislocation was reported in the initial phases a little higher, but that has also been stabilized with a better understanding of the scientific principles. The indications could be post-cataract surgery corneal edema, which could be aphakic bullous keratopathy or pseudophakic bullous keratopathy, advanced Fuchs endothelial keratopathy, failed previous grafts mainly due to endothelial rejection, iridocorneal endothelial syndrome with corneal endothelial failure, CHED or congenital hereditary endothelial dystrophy, posterior polymorphous endothelial dystrophy, any other causes where endothelial failure has led to corneal edema, and occasionally failed previous DSECs. These are just clinical pictures of corneal edema post-cataract surgery. Sometimes the intra-op damage to the endothelium is much more, or sometimes because of the TARS, these patients would develop corneal edema. As you can see here, these are non-recoverable corneal edema and which requires a surgical intervention. Sometimes some of these patients would be highly symptomatic, and many a times that leads to quite, inflamed ocular surface. Patients of Fuchs endothelial corneal dystrophy with central corneal edema would be ideal candidates for DSEC. Coming to DSEC disc or donor preparation, the donor preparation can be done two ways, manual preparation as well as automated with the help of microkeratomes, which is known as DSAK, which I mentioned earlier. There are various types of artificial anterior chambers available and which are being used by surgeons depending on their choice for manual preparation. And now with recent advances, most of the eye banks do provide us pre-cut tissue prepared at the eye bank by a trained technician, so the life has become much more easier. The instrumentation for donor preparation could be artificial anterior chamber to mount a corneoscleral button, various lamellar surgical dissectors, punched refines to cut the desired size button for DSEC or DSAK. The artificial anterior chambers could be disposable, which are, various types of chambers are available, like Baron artificial anterior chamber, cornet with steel base or for better stability, or sometimes reusable steel artificial anterior chamber, or the ones which can be used with automated microkeratome like Moria, etc. These are the clinical, schematics of artificial. This is very commonly used artificial anterior chamber, which is developed by Catena, which is disposable. Essentially, any artificial chamber would have three components. The bottom piece, which is, if you can see my the arrow, the cursor, this is a piece on which the cornea gets mounted, the corneoscleral button gets mounted, which is a pedestal for the corneal tissue. Then this is a second component, which is known as a tissue retainer component, and the third component, which is a locking ring, as it is seen here. Component 1, component 2 to retain the tissue in its position, and then we have to lock this ring so that the tissue doesn't move and the chamber remains tight. So donor cornea with a scleral rim of 14 to 16 millimeter diameter should be sufficient enough for most of the artificial anterior chambers. These are different examples of different chambers. Like this has a steel base, heavier base for better stability. At times you can have non-metallic chambers available, which are also disposable, or you can ETO and use it. Particularly this chamber is very useful for a corneoscleral button where there is a very small scleral rim available. Sometimes depending on the procedural aspects of individual eye banks, we may have very small scleral rim available. In these two pictures demonstrate the steel artificial anterior chamber wherein a cornea is mounted in a similar fashion, and then there is a top piece which allows the microkeratome to be fitted on it, and we can make a pass with a microkeratome, 350 or 300 micron microkeratome, and the cornea can be sliced. This video just demonstrates a manual donor preparation. The cornea is mounted on a disposable artificial anterior chamber. A small cut is made at the limbus, and then gradually the lamellar pocket is dissected. With the initial cut is done with a crescent blade, and then with blunt dissectors, straight, slightly curved, and then fully curved dissector, depending on which area you are working with. And it is important to dissect the cornea right up to the limbus so that you have a maximum size of the donor available. And it's essential that you mark the area of your incision so that you don't lose the site. You don't end up into punching the button while, missing this particular area. Once the donor is prepared, a desired size of dissect donor tissue is cut on a punched refine. As you can see here in a punched refine. Now that area is showing an area of an arcus, so you can avoid an arcus. There are 4 dots or holes. So based on that, you can center your tissue very well. And depending on the size which you require for the donor dissect lenticule, you can use 7.5, 8, 8.5 or 9 millimeter punch and cut the cornea. And you can even recheck from the upper part that whether it is centered well or not. Once you have done that, it is essential that you lift the posterior disc with the help of forceps, one half and the other half, to make sure that you have kind of, separated it completely. This is a second video of a similar mechanism. Here we are using an 8 millimeter punch. You can hear the snap when you are pressing with the 2 fingers. And then you can lift the punch, and the cornea would be cut very well centered, and you can have a thin, graft available to you. It's essential that you rotate the graft or the, block 180 degree and check whether the cornea is punched from all the sides to avoid any, surprises later on. Just to complete these, though, I'm talking on donor preparation and the insertion techniques. Once you have done this, it's important to prepare the recipient. You dissect the main wound, put 2 side port incisions, decide the size of the donor which you want to insert. So based on that, you have to mark the outside cornea with the help of a marker, and then use a Reversinsky or any blunt like instrument which is used for scoring the Descemet's membrane. You score the Descemet's membrane in 2 semicircles to make sure that you have scored it to 360 degree, and then gently lift the Descemet's with the help of the same scorer and bring it towards the main wound. Enlarge the wound with your microkeratomes and remove the Descemet's membrane with fine forceps, and make sure that you put the Descemet's membrane on top of the cornea and check the sizing of the removed DM to make sure that you have done a good removal of the DM or desired removal of the DM, and then remove the remaining viscoelastics from the anterior chamber. Coming to the donor graft insertion techniques, after enlarging the wound to 4.5 to 5 millimeter, the surgeons use one of a variety of techniques to insert the graft into the anterior chamber, often employing specialized instruments to help protect the endothelium. Essentially, there are 2 types of techniques being used for dissect donor graft insertion. One is push technique and the other is a pull-through technique. An ongoing evolution of the devices and techniques used for Descemet stripping endothelial keratoplasty led to various techniques. In addition to performing the surgery with forceps, more and more surgeons are preferring to use glides and injectors to lower the endothelial cell loss and aim for better outcomes. So initially, people use various techniques like insertion with Utrata forceps, where the donor disc is folded into a taco fold in the proportion of 60 and 40. 60 is the top side and the 40 is the bottom side, and a thin layer of cohesive viscoelastic is put in between to prevent endothelial cell loss, and the taco is held with the help of forceps, various types of forceps, and it is inserted into the anterior chamber from the main wound. One can use a variety of endoglides, use of endoserters, and some surgeons use suture pull-through technique, and even recently people have switched over to push technique with a 27 gauge or 30 gauge needle. The surgeons who use forceps commonly take the donor tissue that is on a disc, fold it into shape of a taco, 40 to 60, which I said earlier, for the so-called taco fold, and then use the forceps to insert the tissue into an opening into the anterior chamber. Here you have to grab the tissue. I don't have a video of a taco fold technique because I lost some of those videos. Initially, I used to use that and gradually transitioned to the other techniques. So opening into the anterior chamber. Once the tissue is in the eye, the taco unfolds. Various types of forceps are used, named Utrata, Guzi, or Olga, sometimes Kelman and McPherson forceps. However, forceps and Tecofold techniques seem to cause a higher rate of endothelial cell loss, reaching as high as 30% to 35% at 6 months, and that is why people moved on to use other techniques. This is how essentially a taco, the lenticule is converted into a taco. The top fold is 60% and the lower fold is 40%, so that it is easier to unfold this tissue, and one can insert a bubble underneath the between the two folds, and the taco would unfold. So as you can see here in the picture on your right hand side. So concerns over minimizing the endothelial
conclude, Dr.
Yeah, I mean, I just would have just a couple of slides only. I can move on to conclusion. There is one small video insertion with a Busin glide, wherein this is a courtesy Dr. Vikas Mittal. Descemet button is it is a pull through technique. It is inserted into the glide, and it is positioned into the mouth of the glide, and then with the other side of incision, a forceps is used to pull the button into the anterior chamber. There are various other types of glides, like tan endoglide is available, which essentially uses very minimal size of incision. As you can see here, the lenticule is folded, and we are minimizing the endothelial damage. One can also use endocertus. Just two more videos, and then there is probably a concluding slide. Yeah, 30 seconds videos, Dr. Chitra. This is a push technique wherein donor lenticule is put on a cohesive viscoelastic, and it is pushed through the main wound with the help of 26 gauge or 30 gauge bent needle, and then the wound is sutured, and an air is injected to get the donor lenticule into the center of the AC. Sometimes the donor lenticule is not very well centered. You need to use another instrument to center it well. At times, the surgeon would modify this technique to one can use a sheath glide to support that lenticule, but one can use the same tissue, the posterior part, the anterior part of the tissue, and fold, put a viscoelastic onto that and put the lenticule on that, and use both the things together and slide the top lenticule into the anterior chamber easily, so that there is a minimal tissue damage. Smaller the incision is better, the air management, and lesser the astigmatism. Suture pull-through works better in a phakic or vitrectomized eyes. These are the results post-operatively. As you can see here, sometimes the long-standing corneal edema may take a little longer time to clear up. One can resort to non-Descemet stripping desec, that is N-desec, post-RK, or sometimes post-keratoplasty, failed grafts. To summarize, DSEC or DSAK allowed a transition from full thickness procedures to laminar endothelial keratoplasty with very good long-term outcomes. The learning curve can be shortened by wet lab trainings. It enjoys lower rejection rate as against full thickness grafts. Unaltered topography enables quicker and better visual recovery for these patients and avoids suture-related problems. And pre-cut tissues have helped shorten the surgical time, and you can have wonderful visual outcomes, and patient and surgeon both feel happy at the end of long-term outcome. Thank you for the kind attention.
Thank you very much, Dr. Paras. That was a very thorough talk. Dr. Rajesh, could you just take one question and we'll go on to our next speaker?
Yeah, that's a very nice comprehensive presentation. The only question that I have for the benefit of the postgraduates is there any tips of preventing post-operative dislocation of the donor lenticule, which we know is one of the most common complications of DSEC surgery? And in terms of donor selection, what is the ideal thickness of the donor lenticule?
If the lenticule is thicker, the chances of dislocation is much higher. So if it is thinner, it is better, and one can use a good amount of air tamponade initially. Like, you can spend a little more time to support the lenticule with an air, and then decompress the air to make it 80%, so that it is almost as size of the donor lenticules, so that you know that you are not really going to have high post-operative pressures or pupillary block, and you can avoid, having dislocations of these lenticules. Especially for vitrectomized eyes, it is important to use maybe probably a suture or suture pull-through technique, and maybe to kind of use that suture to support that lenticule to prevent dislocations.
What about the role of using non-expansile mixture of SF6?
Some surgeons do use it, but most of the time one can do away with air, but one can definitely use, non-expansile gases also for internal tamponade.
If there's a small peripheral separation, would you observe it or would you do a rebubble?
I would like to observe it, and sometimes if it is, if it is like, if you don't want to wait, and then maybe probably you can just put in a small air bubble and it will take care.
I think I'll go on to the next speaker. There are a number of questions I'm sure we could have asked. We'll keep it for the end. Our next speaker to take on is Dr. Siddharthan, who's going to be talking on topic DMEC, the final frontier. He's a consultant cornea and refractive services from Shankara Group of Hospitals based in Coimbatore, an extremely versatile cornea surgeon of great repute. Let's hear from you, Dr. Siddharthan.
You're able to hear me now?
Yeah.
Yeah. Okay. First of all, at the outset, I would like to thank the ARC team and Dr. Chitra for giving an opportunity to be a part of this teaching program. The topic given to me is Descemet's membrane endothelial keratoplasty, the final frontier. Of course, it's almost the final frontier because there has been a great transformation of the endothelial lamellar grafts from DLK, from PLK, DLEK, and DSAC and DSAEK. And now the most refined or almost refined one is the Descemet's membrane endothelial keratoplasty. So DMEC actually involves, it's a very precise surgery involving only the transplantation of the Descemets and the endothelium. And it gives almost a near perfect anatomical replacement of the endothelium. And it does not need any costly instrumentation. It's a very simple mechanics involved. But only thing is that it has a steep learning curve. So just as we started doing phacos, every surgery has a learning curve, and this is a very soft cataract which we usually try to do it. Once we master it, we try to go and do hard cataracts like NS4, even under a topical. And still more, what we do is even when the cornea is a little bit hazy or having scars, we try to do. So this is almost like that, like from doing a clear phaco to doing a very hard cataract. DMEC, of course, has a very steep learning curve. So that is what actually makes it a little bit a challenging surgery. And one more thing is that if there is any problem, always there is loss of tissue and you have to look for another tissue. So what are the problems we can face when doing a DMEC is that when we remove the tissue preparation is a little bit challenging because the Descemets is having very strong hemidesmodermal attachments to the stroma, and sometimes when you remove, you can have piecemeal removal, you can have damage to the endothelium, and when you're injecting, it's very fragile, so you can get caught into the tunnel pushing, and all these maneuvers are very dangerous and very detrimental to the endothelial cells. So, and also unfolding, all these things, there is a very steep learning curve, and unless you are a good DSAC surgeon, it is difficult to directly upgrade yourself from PK to DMAC. And also sizing of the graft, everything is very, very important. So I almost doing DSAC for almost 10 years, and now for last 6-7 years, not doing DSACs, even though with such good results. You can see all these were about 5 years, 10 years back. But why did I shift to DMAC was because sometimes of 4 or 5 millimeter section, you have astigmatism, and because of this intrastromal haze and all these things, you don't get a near perfect 6.6 in DSAC. Most of the times you get 6.9 or something, but to be precise, I think DMAC is the surgery. And just a little bit of literature for the PG's work, like DMAC, there have been like almost 500 publications, but in Asian eyes, there have been very few publications. And I feel that why it's not being practiced is because first understanding that orientation of the DM scroll is very, very important. How to remove the DM. There has been no standard prototype injector, and very comfortable with DSAC. Everybody is very comfortable with DSAC. So all these things finally lead to no standardized technique. Like when you do a FACO or now even a DSAC, there are standardized protocols. But now for DMAC, there are no standardized protocols. And last year we published a few standardized protocols, and even relative contraindications like eyes had very good results. So I feel that the major contraindication for a DMAC is there is no iris tissue or significant stromal scarring. Other than that, I think if there is an endothelial problem, DMAC can be done in most of the cases. Coming to the basics of DMAC surgery, for the postgraduates, like we always read, the endothelium scrolls on itself, and this is how the endothelium scrolls exposing the DM scrolls exposing the endothelium out. In real practical life, you can see that I'm putting the endothelium like almost like a taco fold. The endothelium is inside, and when you put it in the saline, this is the tendency of the DM to unfold itself in such a way that the endothelium comes out. And that's why when you handle the endothelium, there is a lot of damage, and that's why there is a lot of concern among surgeons performing DMAC. The second is the procedure as such. So what I do is I first mark with a 10 mm a trephine, and then with the trephine blue, I mark the edges are marked, and with the plain Sinski, I just score the DM without any tags. As you see that I don't lift up the Sinski, I just keep going. So once that is there all over 360 degree, you can actually fold the DM. But it's not as simple as that always. You can see here, when I'm pulling here, there is a little bit of resistance. So this is when you keep pulling, it will tear. So always take care in a young tissue. Go to that particular area where there is a hold there, where there is a attachment. So mostly you can see that how it is attached so tightly in all these young tissues. So you can go point to point and you can do. Actually, there is no standard technique, but you can actually modify and be very careful and gentle. So actually without the main, only important thing is do it without tags when you do the with the Sinski. So that is very, very important. The second thing is once after you put it one half, then you make a small stromal window with a 3 mm trephine, and then you open up the window for a mark. So this is basically for knowing identifying the side of the DM. So for example, you attach it, it should be like L-shaped or F-shaped or whatever we call. I use an L, where I use an L-shaped mark, sorry, where the horizontal limb is shorter and the vertical limb is longer, so that when you rotate it, I always orient it that the shorter horizontal limb is always on the right side, like as if you're sitting on the side of the L and then seeing. And people are comfortable with F, S, and whatever position, until it helps you to identify the position of the DM inside the antechamber. And prototype engineering, this has been, I've been using this from day one, like last 5 to 6 years. A simple 1cc syringe, a FACO tubing, and then a regular IOL-3 cartridge. You cut and you attach, and your injector is ready. You have to fill up this injector with saline. This is a normal IOL tub, and I fill it with BSS and the syringe also. So once I punch, I take the DM out and put it into the IOL tub, and then with the injector, I suck the DM into the injector. So now the tissue is ready. The key important steps in DMAC in the recipient is that you have to remove the epithelium. That's very, very important for two things. One, the view is better. So your attachments, everything is better when you remove the DM. And second, post-operative healing is much better because all these devitalized epithelium is, when you remove it, it heals faster. Then I put two side ports, one at 12 o'clock, and you see the entry is straight. No, I don't use a bi or triplanar. It's just a single entry, because anyway, I'm going to put a suture. So when I inject, it is easier. Then pilocarpine is applied to constrict the pupil, and doing a PI is very important here. And then I do a slit PI, don't do a round or oval, because when you do a larger PI, the tissue tends to move towards the PI. So make it as small as possible, and slit shaped is very important in preparing the tissue. Second, the tunnel, I just want to show tunnel, make it 3 to 3.2. Don't make it too small, because when you inject, you can see that when the saline comes out, the tissue comes out. So be a little bit generous in the size of the suture, so that the saline flows out when you take the injector. And removing the DM is similar. I think Dr. Parash showed the same. Only thing what I want to tell you here is don't touch the stroma. That is very, very important, because if you want a pristine cornea, then it's better not to touch, because the moment you touch the stroma, definitely scarring will occur. You can see that I don't really touch the stroma at all. Once I remove, I keep removing only the DM, and it comes out really very well. And the unfolding techniques, there are 3 types of unfolding techniques I want to tell you. Here, first, once you inject, the most important thing is make sure your entire injector is inside, injected, and then always apply a suture before you manipulate. Whatever the tissue, the configuration is, don't worry about it. First, put the suture and secure the tunnel before, because it's very fragile. You start manipulating, it will come out and there'll be a lot of damage. And this tissue is almost a 60-year-old tissue, so always start doing DMAC in an elderly tissue around 60, 65. And you can see that gentle tapping. This is how previously it was done. So nowadays these tappings are not done, but you can see that previously we used to tap, inject a little bit of saline, create a space, and then you tap. So as you tap, this elderly tissues opens up very well and faster. And this is used to be the regular technique of most of us. You can see the L is on the right orientation. And once it is done, I inject air to fill up the space. I'm just positioning it to the space, and then I'm injecting air to oppose it. The second technique is if you try to do it and it's not opening up. Okay, so what you can do is I try to place it a little bit horizontally, and then you can use a two-hand technique. Two-hand technique means with both the hydrocannula, you can inject a little bit saline for space, and then slowly with your cannulas, you can just slowly give tapping movements and you can open up. So this is another technique. When it doesn't open up very well, you can do it like this. Gentle taps are enough. So this is the second type of way how you unfold a DM. Now what we use is a hold and release technique. This is the final technique how we use. You see I place it horizontally. With the left hand, I hold the periphery of the DM, and you see that I inject, I shallow, I inject, I shallow, I inject, I shallow. See, that's how it just opens up very beautifully. No tapping, not much of endothelial damage, and you see that L shape is seen. Just again reinforcing that. Just make it horizontal, hold it with your left hand, inject saline, shallow it, inject saline and shallow it, because this is where people find it really difficult, and this is where you have the maximum endothelial cell loss. So just look, I just position it to that place, and then shallow the anterior chamber, inject saline, shallow the anterior chamber, and it opens up so beautifully. So these are the few techniques which I just wanted to show, because being a postgraduate, this thing, it's a very simple method of unfolding and doing the procedure. So when you do it, as I told you, don't touch the stroma, use the injector meticulously, and with a very fine tapping movements, you can get such very good, clear results with good endothelium. Thank you.
Thank you very much, Dr. Siddharthan, for being very precise and well within time. I just want to ask a very simple question. Understanding that the usage of steroid drops, knowing that DMEC, the chance of ejections are so much lesser, would you consider using Lotipred instead of Predfort, or would you use Predfort only? And
so the first one, yeah, for the first 1 year, I prefer using Predfort, prednisolone 1%. I prefer using for 1 year, and then after 1 year, I prefer to use Lotiprednol. So like 4-5 years follow, we have not seen, we have seen a few rejections, but that time I like to use Predfort, but most of the times after a year, we use only Lotiprednol.
Dr. Rajesh Fogla.
Siddharthan, would you care to comment on ultra-thin DSEC or nano-thin DSEC versus DMEC? Because recently those techniques have also become popular, and the visual outcomes seem to be comparable, and also the rejection rates are also quite similar between the two.
Yes, Dr. Rajesh, I feel that ultra-thin DSEC and all the thinner versions are now, I think, I feel that is also very good in the recent times. And because most of the times what we have seen in DMAC is the cells migrating, and the cells at the end of 2 years, 3 years, it's almost 1,000, 1,200. So we don't know in around 5 to 10 years what it really happens. So I feel that ultra-thin DSEC or wherever the manipulation is much lesser, I feel that also has a role in the future.
I think I'll go on to our next speaker because of the paucity of time. Our next speaker is Dr. Ashish Kumar, who is going to be talking on graft rejection and failure, one of the young dynamic ophthalmologists with great promises, with great good surgical prowess, and practicing conjointly with his family of ophthalmologists in Patna. Let's hear from you, Ashish.
Thank you so much, Dr. Chitra. My slides. Just share my slides.
Try to keep within your time.
Yeah, sure. Are my slides visible?
No, not yet. Come to screen sharing.
Yeah. There. Not able to share.
Could you start again and see?
Let's see.
You had done it before, no?
Yeah.
Yeah, can you just open your presentation and then click on share screen once, and then share the right hand side blue button which says share. Just click on share screen button once, and on the pop-up, just on the right hand side, just click the share, the button, the right button, right bottom.
Yeah, I'm doing that.
It's getting closed again and again. Yeah, perfect. Just open your presentation, doctor.
Are you able to see now?
Yeah, yes.
All right. So thank you. At the outset, I'd like to thank Dr. Chitra and team ARC for giving me this opportunity to be amongst the stalwarts of cornea in the country. And so after listening to all the types of transplants, PK, Descemet, DMAC, let's talk about the dark side of the transplant. So I'll be talking about graft rejection and failure for the next 15 minutes. Okay, so corneal transplantation, as we know, is considered the most common and successful tissue transplantation procedure in medicine. But yet, there is no standardized protocol for post-operative prophylaxis and the treatment of immunological rejection till date. The majority of corneal grafts occur as first transplants in low-risk recipients, such as those with keratoconus and dystrophies, where the survival rates are very good, more than 90-95%. The problem is with the high-risk grafts. High-risk grafts are like eyes with 2 or more quadrants of vascularization, larger grafts, herpes simplex keratitis, uveitis, previously failed grafts, infected hot eyes, which unfortunately is the most common indication of graft in our country, and when the recipient is young. Previous surgeries, particularly glaucoma, anterior iris synechiae, and vitreous sedation, all raise the rejection risk of the transplanted graft. Just to see things at perspective, Sir Peter Medawar in 1948, he was the first one to experimentally analyze the immune response in the eye. What he did was he injected skin graft into the anterior chamber of rabbits, and what he observed was the skin graft which was close to iris was rejected, and those which was adjacent to endothelium survive. And thus he concluded that the vessels are crucial for a sufficient immune response against foreign tissue. And for the same work, he was awarded Nobel Prize in 1960. So cornea is blessed. Cornea is avascular. There's an absence of lymphatic vessel in the central cornea. There are presence of secretory immunomodulatory factors which have inhibitory effect on variety of inflammatory cells. Corneal endothelial cells promote apoptosis of CD95 T cells. Additionally, corneal endothelial cells express very low levels of MHC molecules. So because of all these reasons, it's considered as a relatively immune privilege. Also, the biggest advantage with us of the cornea is that we can apply immunosuppressives directly on the cornea, like topical steroids can be used, right? But still, in spite of all this, allogenic rejection is the commonest cause of graft failure. Let's look at the incidence of rejection. Any reported incidence of rejection in any series will depend upon the indication for graft, type of graft, and other factors like high-risk graft and young recipients. Low-risk PK, the incidence of rejection is around 5 to 17%, whereas in high-risk PK, it can go up to 68%. DALK, DSEC, DMAC has a very low incidence of rejection. 30% of the graft is still experience at least one episode of rejection, and 5 to 7% lead to eventual graft failure. Endothelial rejection, which is the most common rejection which we see, it presents as limbal injection. There were cells in the aqueous. We'll see KPs, choroidous line. Sometimes you will see a choroidous line is seen only in a longer established rejection advancing across the graft and associated with corneal edema. Corneal edema happens because of the localized endothelial cell injury. We can also see sometimes epithelial and stromal rejection. Stromal rejections presents as nummular subepithelial infiltrates, and whereas epithelial, you'll see epithelial rejection lines. These are very uncommon, but still we see sometimes. So the timing of rejection, usually we see endothelial rejections at the end of a year, or maybe probably next in the early next year, after 12 months, around 12 months. But sometimes rejection has been reported even after 9 years. And contrary to this, you see rejection in solid organ transplant in the first 3 months, actually. So the management of graft rejection. So basically, if the rejection begins, it must be reversed before irreparable damage is done to the endothelium. Rates of reversibility of severe endothelial rejection are between 51% and 64%. Topical corticosteroids still remains the mainstay of therapy for graft rejection, but there is still very little information on the optimal steroid doses and the route of administration. Before we go to the treatment of rejection, let's see what is the common practices for post-operative care. So either we use topical prednisolone or dexamethasone. Topical prednisolone should be used because it achieves high level of aqueous concentration within 120 minutes, and it maintains a significant level over 24 hours. Whereas dexamethasone attains peak levels faster than prednisolone, but the levels which we see in aqueous is much less than prednisolone. And after a year, so we can switch to softer steroids like fluoromethanol or loteprednol. Steroids for life. I use steroids for life, whether it can be predford, dexamethasone, or soft steroids. Other immunosuppressants has been tried like cyclosporin and tacrolimus, but still their role is still debatable. Although tacrolimus has shown some promising results, mycophenolate mofetil, azathioprine, cyclophosphamide, rapamycin, and other biologics, still their role is not proven. So the prompt and appropriate management of rejection is very important to reverse it and keep the graft still clear. So decision on the choice of route and doses of steroids is very important. So what I follow is, if the patient is off topical steroids, like in a DALC after a year or DSEC after a year, and or using very infrequently, what we do is just increasing the frequency of steroid will reverse the rejection. But if the patient is using frequent steroid and still develops rejection episodes and it's a high-risk recipient, it's better to start systemic steroids. Some patients are unable to tolerate systemic steroids, so you can also give subconj DECA helps in those cases. So the treatment of graft rejection, like using systemic steroids, is still very debatable. IVMP has been tried, but there was no difference in terms of reversal of graft rejection episode, later recurrence of graft rejection or graft failure. Subconj triamcinolone has shown some superiority over intravenous methylprednisolone, but we do use it subconjunctival sometimes, but not always. Likewise, there was no beneficial effect of cyclosporin or tacrolimus in the reversal of graft rejection. Most importantly, we have to find out if we have treated rejection, they should not. We should prevent further episodes. So we should be identifying what are the inciting factors for rejection, like loose sutures, vascularization, or non-compliant to drops. Or if it's a high-risk graft, you have to keep on using steroids. Topical steroids for life, gradually tapering into once or twice daily should be practiced. In spite of all this, we have given appropriate steroid therapy in rejection, but still the graft clarity is worsening. So that is the time when you have to rethink about your diagnosis. Like this case, looks like typical graft rejection, but it wasn't. So this case, this patient was operated for PK for keratoconus in May 2018 and was switched to loteprednol in once a day in July 2019. And then it presented like a graft rejection, and then there was no improvement with topical steroid over a month. Then we did AC-TAP, and then we started AC-TAP came positive, and when we started the patient on valganciclovir, and slowly over the period of 2 weeks, we started seeing a drastic improvement. So why we have to think why it is CMU enterolitis and why not endothelial rejections? First of all, timing of presentation. Usually severe endothelitis presents early in the course of graft, and you have to see the pattern of KPs. These are usually coin-shaped or pigmented KPs associated with high IOP and worsens with the steroids. So like in this case, this is a picture of typical coin-shaped KP. And if the diagnosis is missed over the period of time, what happens is corneal decompensation, and then this patient had corneal decompensation and underwent DMEC after 12 weeks of Valgan, and doing very well now. These are the similar pictures where we have seen endothelitis after DMEC and PK. So coming to graft failure, if graft failure is defined as the failure of corneal transplant to restore adequately the visual function of the patient in the absence of concomitant pathology. Corneal graft failure is one of the most common indications for corneal transplantation now. Most common causes of graft failure are endothelial decompensation. It could be secondary to rejection, and it could be just a primary graft failure. So primary graft failure is defined as presence of a diffusely edematous corneal graft on the first post-operative day that fails to clear at any time post-operatively. Usually is the result of inadequate donor endothelial cell function or during surgical trauma while doing the surgery. Timing of regrafting is very important in these cases. I think it should be done as soon as possible because the body is still not sensitized to this graft, and we know that graft survival decreases with every successive graft. So we have to, if it is not getting clear in 2-3 weeks, then we just have to change the graft. This is the 5-year survival curve for successive grafts. Here the graft survival rate fell down from 72.5% for first graft to 18.6%. That's why we have to do it as soon as possible. Secondary graft failure, it is defined as the presence of diffuse and irreversible corneal edema in a previously functional transplant as a consequence of endothelial failure from immunological or non-immunological causes. Timing of regrafting, like we can wait for 2-3 months, and since the body is already sensitized, so there is no urgency. This is another type of graft failure, which is called morphological graft failure. It refers to clear grafts without transparency loss, but conferring poor visual function as a result of severe irregular astigmatism. I think Dr. Praveen is going to talk about management of these cases. So now the most difficult thing is to choose between which type of regraft you want to do. Nowadays, since all the corneal surgeons are preferring lamellar transplant over full thickness transplant, so the choice is becoming more difficult. The survival of replacement grafts had greater association with the number of prior grafts than primary corneal diagnosis or type of regraft procedure. Lamellar transplants have quantitatively less alloantigen than full thickness donor corneas and would for this region be expected to have higher rates of survival. Here we see the survival of DMEC, success of DMEC is 97.4% at the end of 5 years compared to PK, which is just 54.6%. This is another study where they compared EK versus repeat PK after failed PK. What they found is a meta-analysis. What they found that the survival in the first year, 3 years, and 5 years between EK and repeat PK was almost same, but the number of rejection episodes were much higher in repeat PK compared to EK. So EK should be done for a failed PK now, if possible. So how to decide what type of graft you want to? The first question to consider is whether an EK might be performed. Next question, whether the existing graft at its best ever provided patient with useful vision. If, for example, the graft profile was excellent, affording the patient a high level of aided or unaided vision before failure, then every effort should be made to maintain this with an EK. At the other extreme, if the profile of the graft was highly irregular even before failure, then it may be more advantageous to attempt a redo PK and improve on the existing level of astigmatism. So DSEC or DMEC under failed PK, the results were almost similar, except that DMEC actually is more challenging to do under PK in the initial period, and a DSEC is easier to do, but the results were slightly better for DMEC compared to DSEC. This is a 5-year survival curve for successive regrafts. For any combination or permutation, the results were same, like for EK, EK, PK, PK, or PK, EK, or EK, PK. So if we are planning a DSEC under previously failed PK, we just have to keep few things in mind. Always do AIOS-OCT, see the graft house junction. If it is too irregular, trim it, make it regular, and try to plan a smaller graft which comes under the rim of the already done PK. And if you are planning a larger graft, then at least 2 mm larger in size of DSEC is preferable. In conclusion, I would say topical corticosteroids remains the mainstay therapy in preventing immunological graft reactions for all types of corneal transplant. Consider differentials like CMV if the graft rejection fails to reverse in spite of prompt steroid therapy. Graft failure has become one of the most common indications for corneal transplantation nowadays. Lamellar cornea surgeries are being adopted quickly by all corneal surgeons due to its superior results and better survival. Regrafting with lamellar technique are a better option compared to PK. Thank you.
Thank you. You covered everything. I think we barely had need to have asked questions, Ashish. That was a great talk. Dr. Rajesh Fogla, I'm going to ask you a question. Is there actually any role of these topical cyclosporin tacrolimus as for rejection?
They may not play an important role in rejection. Steroids still remain the mainstay, but later on, to maintain better immunosuppression and avoid the complications of long-term use of steroids, they can supplement your topical steroids by adding topical tacrolimus or topical cyclosporin 2%. In India, we do have topical tacrolimus available. So they are kind of slightly safer, especially if your patient still has sutures, and if he has a broken suture or something, if he continues to use topical steroid, the risk of a secondary infection is much higher vis-a-vis using topical tacrolimus ointment.
I think we did a randomized control study from RP Center with topical cyclosporin, that to 2%, which is not available commercially. And we found that there was no difference whether you gave topical 2% cyclosporin or not. Rajesh has done yet another study. Dr. Rajesh, would you want to talk about?
Yeah. Actually, we did a study comparing, 2% cyclosporin with nothing along with steroid, and we just followed up the patient to look for prevention of graft rejection, and we found out that the outcome was similar. So cyclosporin, what we concluded was 2% cyclosporin doesn't prevent occurrence of graft rejection in these cases. So as far as graft rejection is concerned, cyclosporin may not help, but it helps in a surface improvement definitely. But we found in our study that it doesn't help in graft rejection.
One of the points Ashish made, sorry.
The only thing that we found out was in another study, we found out that the patients who were treated were given cyclosporin 2%, their reversal of rejection was better than those who were not getting cyclosporin.
Along with the steroids, you mean?
Yes, along with steroids.
One of the points Ashish mentioned in his presentation, if I understood correctly, that IV MP did not perform as well as topical steroids. Am I right, Ashish?
No. It was It was not IV MP. It was just comparing IV MP with other oral steroids.
Okay.
And one more.
So there was no advantage of using IV MP over systemic steroids.
One more study that was done was that IV MP versus dexamethasone, because dexamethasone is cheaper and methylprednisolone is costly, so the patients are not able to afford it. So in the study that was done again from our center in randomized controlled study, it was found that the results are similar. So if the patients are not able to afford methylprednisolone, you can still give IV dexamethasone 100 milligrams. So that also works equally well.
Yeah, that we do sometimes.
We have to ask Dr. Sudhir.
Yeah, we did a study with one of the clinical trial with cyclosporin implant. Actually, they really did very well. These were a slow release cyclosporin, which is implanted subconjunctivally, and they are supposed to be there for a year. But most of the grafts did very well, and they were crystal clear. Unfortunately, I think that study was not, the clinical trial has to be ended because of some reason. But I think in long term, I think we may, this is excellent for high-risk grafts.
Yeah, I do remember. I think RP Center was also a part of the study, and this was initiated from Germany. And what happened was that in some of the cases, the implant that was done actually got exposed, and so it could not be sustained for a prolonged period of time, in the sense that some of them were extruded. So I think that was the reason why that study was discontinued, and the sponsors also backed out.
Shall we go on to our next speaker?
Yeah.
Yes.
We had done almost 20 implants, so they were really had a very good results in that case.
I'll go on to our last speaker, who's going to teach us how to remain premium in corneal surgeries. Is Dr. Praveen Krishna. who's going to be talking on post-keratoplasty astigmatism management. Dr. Praveen, could you share your screen? He is the director and heads the cornea, cataract, and anterior segment services at LV Prasad, winner of some of the most prestigious awards in India and abroad, innumerable publications, and a major presence nationally and internationally, and a teacher par excellence. So let's hear from Dr. Praveen.
Thanks a lot, Chitra, and congratulations to you and the ARC for actually putting together a course on keratoplasty. I think very pertinent and very apt topic for the postgraduate students who have had an overdose of cataract and refractive surgery, I think. So thank you. After listening to all the wonderful talks that you've heard today about managing and doing the perfect surgery in different situations, after you've done a keratoplasty, one of the things that all of us would be confronted with is astigmatism after doing either a penetrating keratoplasty or doing a dark. So what I'm going to cover today in the next 15 minutes or so, what are the factors that influence astigmatism either during surgery or right after surgery? What do you do to minimize astigmatism during surgery? And very briefly about correcting high astigmatism once you already have significant astigmatism. And I'd like to actually say that initially when you start doing keratoplasty, the thought process is you want to achieve a clear graft. And you have a clear graft, most of us are pretty happy. But that is like thinking like a retina surgeon. You have a retina that's attached and you're happy, but the patient is not. I think you need to think like a refractive surgeon when you're doing a penetrating keratoplasty or a DALC, because you want to give the best possible vision to your patient. So here is an example of a patient who has macular dystrophy who underwent a penetrating keratoplasty. And you'll see that this patient has a wonderfully clear graft, very clear, and you'll see that he's had a cataract surgery as well, all sutures out except for one broken suture here. And this patient actually has a vision of 20 by 20 with a correction of 0.75 and 0.75, non-toric IOL in the eye. So what does it take to actually achieve an outcome like this in all keratoplasties? Now here is another patient who had a DALC surgery. But then let's take a break to look at the factors that affect astigmatism in the eye. Now, the factors that affect astigmatism are surgical, they're patient-related, as well as post-operative. We'll focus on the surgical factors. So here is another patient who's had a keratoplasty, and you'll see that this is, again, a very beautiful graft to look at. Very nice sutures, everything in place. And this patient has very good vision as well. This is early post-operative. And this patient has a vision of 20 by 25 with a relatively low refractive correction. Now, if you contrast that with another patient, here is another picture of a very clear graft. Again, early post-op, about 3 months or so. And you'll see that this patient has a hyperopic error with a cylinder and is not correcting beyond 20 by 60. So what is the difference between the first patient that you saw and the second patient that you're seeing right now? Well, if you try and look at the difference between these two grafts, both are clear, but the difference is the fact that when you look at the centration of the first graft, you'll see that it is very well centered on the pupil or on the visual axis as a corollary. In the second patient, you'll see that the centration is nearly not as good, and that is one of the major factors influencing the outcome of keratoplasty. Now, when you also look at the other factors, including suture length and distance of the suture from the visual axis, you'll also see that in the first patient, the sutures are uniformly spaced away from the pupil. But in the second patient, you'll see that some of the sutures are long, like you see up here, and some come very close to the visual axis, which is again the reason why this patient does not have very good vision. So centration, how do you achieve good centration? You can use a number of techniques, but all you have to do is ensure that you center your graft on your cornea. A lot of times there is parallax, especially in cases of keratoconus. So you need to ensure that you mark the cornea and mark the center as well, either with ink or maybe with just a simple technique by using a Sinskey hook to ensure that whenever you start to trifine, you're very well centered on the cornea. This is just marking the center. And once I mark the center, then you use your trifine, whichever kind of trifine, you'll see that the centration is exceptionally good in a case like this, and you can expect a good visual outcome in such cases. Now, the reason why centration is important is if you overlay topography on this corneal graft, you'll see that these sutures that are there on the right side are causing quite a lot of flattening because they're close to the visual axis. And because of this patient is going to have a poor visual outcome. So it's very important to ensure that your sutures are uniformly distant from your pupil, and that is what is going to determine your centration and your visual acuity as well. Now, coming to graft sizing, again, in our residency, we've been taught that we should do the smallest size graft possible. Well, this is wrong. Here is a patient of keratoconus who had to undergo a very large graft because of some peripheral thinning as well. And this patient is post-operative 1 week, and you'll see that his visual acuity already unaided is 20/40. And the same patient at 1 year with hardly any of the sutures removed now has a visual acuity of 20/20 with a correction of just -2 in that eye and no astigmatism. Now, another reason why this is happening is not because the surgeon is exceptionally good, but because of the fact that the sutures are very far away from the pupil. And that's the reason why a large graft in several cases is better than a small graft. Not that you have to do as large a graft as possible, but the optimum minimum diameter seems to be about 8 or 8.25 now to achieve this kind of visual acuity. So what do you do when you have sutures that are tight? So if you have sutures that are tight and these sutures can be removed, you see this is a patient who has astigmatism of almost 10 diopters, vision 20/250. You remove 4 sutures, astigmatism comes down to about 5, and then you remove a couple more sutures, and then the astigmatism comes down to 3.5, and the patient has 20/25. So tight sutures during surgery are also a major factor in influencing the amount of astigmatism in the eye. Now here's another patient of keratoconus before surgery, pretty poor vision, 20/320. He undergoes keratoplasty, and then we've tried to remove sutures by managing the astigmatism. But at the 2 months post-op visit, he has 16 diopters of astigmatism. After suture removal, he has 10.7 diopters, and more sutures, still about 10 diopters, and 7 months post-op, still about 10 diopters. Now, there's something wrong in a patient like this, and you need to examine the host bed carefully. If you see this patient's host bed, you'll see that the entire cone has not been excised. So it's not just sutures. You also need to ensure that you remove the entire pathology to ensure that you can control your astigmatism as well. Now, what about the type of sutures? Here again is a patient with a large cone with keratoconus before surgery. And this is the same patient 1 month post-op with a refractive error of 2.5 and -0.5 cylinder at 130. And this patient has continuous sutures, which again, I like a lot because they seem to give very early stabilization of refractive error as well as visual acuity. And this patient is 20/20 with a low correction in the early post-op period. That's its topography, very regular topography as well. Another important aspect of suturing is graft hose apposition. If you look at this graft and you look at the different parts of the graft hose junction on the OCT, you'll see that there are some areas which are really well apposed and some that are not really well apposed. For example, you'll see there is some amount of gape in the posterior part of this graft hose junction. And if you compare that with another patient who has interrupted sutures, look inferiorly, there are some loose sutures, some short sutures, and you look at the astigmatism in this patient, 15 diopters against the rule. And if you look at the OCT of this patient, you'll see that the OCT shows that the graft hose junction is really not very well apposed, which actually explains why this patient has such high astigmatism. So graft hose junctions that are well apposed are like the one in the top picture, where you have a good anterior apposition. Ones that are poorly apposed are like in the bottom picture, where you see that there is quite a bit of override of the host bed. Poor apposition also leads to loose sutures and also leads to ectasia of the graft hose junction, like you see here. And this results in elevation of the graft, as you can see on the topography, and a flattening of that area of the graft. Now, this is seen on OCT as well as this area of elevation, and this needs to be corrected not by removing sutures, but by putting sutures. And one of the important determinant of having good apposition of your graft by sutures that last long are to ensure that you get good suture depth. What is taught in books is to go to about 80 or 90% of your graft as well as your host bed, so that you have good apposition and you have uniform tightness of your sutures, when you apply your sutures. Now, similarly, sometimes after removing sutures, you have ectasia of the graft host junction. This needs to be repaired. As you can see, preoperatively, there is ectasia on the left side. Postoperatively, after repair, the topography is almost normalized and looks much better. So that's another reason why continuous sutures along with interrupted sutures seem to be a good bet, because they provide a lot more areas of compression. And that's why you have early stabilization of astigmatism in these kind of patients. This is the topography from the previous patient showing you a very nice topography. So what do you do when you have high astigmatism post-keratoplasty? There are a number of methods, but I'll very briefly touch upon 3 important methods after keratoplasty. This is a patient who had astigmatism post-keratoplasty, had an IOL in the eye already. So we did a relaxing incision and a compression sutures. This is an incision that is made inside the graft host junction. And this patient did really well at 1 month, where he had astigmatism come down to only 1.5 and his vision was 20 by 25. If you have very high astigmatism, like in this patient, very high against rule astigmatism, almost 11 diopters, you can do a toric IOL or a toric phakic IOL. This patient ended up with 20/30 vision after a toric IOL inside the eye, because she also had a PSC in the eye. Similarly, one of the other methods that you can use, this is an eye trace that shows that the internal astigmatism is cancelling out the corneal astigmatism very nicely in this patient. Another method that you can use is also to do a surface ablation. This is a post-DALC surgery where we did a PRK for a patient who had a -5.5 astigmatism, vision improving only to 20/25. Topo-guided PRK in the same patient gave him a 20/20 vision with a lower amount of cylinder that he could wear glasses in. So to summarize, the factors that affect astigmatism that we saw so far are mainly surgical, centration, suture length, the size of your graft, the host bed, kind of sutures you use, the graft host junction, apposition, and a number of other factors. But there are 3 things that you must remember when you're doing keratoplasty: that most of your astigmatism comes from the time of surgery, not after surgery. So you need to put in as much effort as possible to reduce or minimize this during surgery. If you have an elevated graft host junction or high astigmatism that you can't control, you need to decide between removing sutures versus applying sutures, because both are equally effective in the individual cases. If all sutures are out and you have high astigmatism, you can use relaxing incisions, you can use PRK, or you can use toric IOLs to correct this astigmatism. So thank you very much again for the opportunity. And I hope you remember those 3 take-home points.
Oh, that was an excellent teaching video. I mean, I don't think I'll forget a single sentence which you spoke today. How effective are these topo-guided PRKs on these post-graft corneas?
Most times it seems that topo-guided PRKs, at least I reserve them for DALC. I do very rarely for post-PKIs. They seem to be a 2-step procedure rather than a single-step procedure. So most patients, if they're willing for 2 steps, I do it as a 2-step. If not, I just do a wavefront optimized single-step PRK, because that does not result in an increase in myopia. But quite effective, very effective.
Dr. Rajesh, you have some questions to ask? Dr. Rajesh Fogla.
I think Praveen has given a very structured talk and he has covered most of the points. And I think what I liked was the relevance to the surgical technique, because that's the most important step in preventing astigmatism. Management is definitely also challenging as well, but I think if you can prevent the astigmatism, that would go a long way. We can ask Dr. Titial. I think they have done ALTK also by making a flap first, and then you have done the LASIK later on, and the flap has also reduced the astigmatism in post-keratoplasty eyes.
I think, Dr. Namrata will be the right person to answer this.
Oh, okay.
So I think we've described 2-step technique, where in first step 1, we've just lifted the flap and left it like this, and put it back. And then 6 to 8 weeks later, we again relift the flap, because when you make a flap, then also some of the tension lines are relaxed. And that also acts like a keratotomy and kind of decreases the astigmatism. So that takes care of about 2 to 4 diopters of the cylinder. And then whatever residual is left, you can relift the flap and correct it after doing LASIK on it.
What flap thickness did you prefer to use for such cases?
We prefer to go a little deeper, and we prefer to go because you are trying to relax the tension lines which are at the graft host junction. So more than the depth, it is the size of the flap that is more important. So you try to encompass that also. So you go in for larger flaps, and they have to be a little deeper. Otherwise, it will not cause the relief of the stress lines.
In that study, we had taken a 9.5 millimeter suction ring and 160 microns flap, if I remember correctly. And the average correction just by flap creation was 2.48 with a standard deviation of, I think, 1.25 or something.
We missed out on that talk on during COVID era, the challenges of doing a corneal graft, corneal enucleation. Yeah.
All of us are having challenges.
No.
Banking in
the question is, if a person appears to die a natural death, so would you take those extra precautions, do a COVID test along with the other battery of blood investigations? How would you deal with those situations?
So, Dr. Tityal, sir, would you like to answer that, sir? Yeah, for the protocol that we follow at our center and the protocol that is followed everywhere else is a little different.
Yeah,
sir?
I think we in AIMS, we have put a policy now to get a RT-PCR sample from the donor nasal pharynx. We do RT-PCR, and after that we, as such, we have to keep the tissue for at least 40 hours, 48 hours in the medium. So that gives enough opportunity to get a RT-PCR test done, a result. And we do all other tests also. And that is just now it is implemented. And I'm sure in next few months, if the cases go down like which is happening in the country, maybe that may not be required.
As per the directive of the Ministry of Health and Family Welfare, it just says you can retrieve the eyes taking adequate precautions. It doesn't say that RT-PCR is mandatory.
Dr. Rajesh, you have any other question to ask before we conclude?
No, Dr. Maipal sir would like to say something, sir.
No, I am a wrong person for the symposium, so I just listened and refreshed my memories because it's been quite some time since I did a graft. But obviously, there have been a lot of revolutions that have happened in corneal surgery, and the outcomes have become much better. So I think all these speakers did great justice to it, and the partial thickness or the breaking up into the various layers is the greatest innovation, I would say, over the last decade happened, and obviously has reduced the incidence of rejection and has improved the outcomes. Regarding the corneal eye bank donation, I think what is very important today is that it was stopped the home retrieval, and most of you might be aware that it's only with the effort of Namrata, I would say, as also the Eye Bank Association, AIOS, the Cornea Society, etc., that we represented, and now the retrieval has been re-allowed by the government. So I think the testing of RT-PCR or RAT or whatever has not been, as Namrata rightly pointed out, has not been said anything by the government. So I think it will be an individual thing whether one wants to do that or not, depending upon how the patient, like what is the reason for the death of the patient. More often than not, I think people who have unnatural deaths or something, they might be undergoing a COVID test because the number of tests, at least in Delhi, are almost about 1 lakh a day. So I think lots and lots of people have got that done, especially those who get hospitalized. So that is regarding the grafting part that you asked about the eye banking. But I think the numbers have gone down dramatically. I think I may be corrected, but in the last 6 months, the retrieval is down to 30%, I suppose, of last year.
Yes, sir.
Yeah, so that is the kind of impact that COVID has had as regards the availability of the corneas and the number of surgeries that have been done. So I think with the other things picking up all over India, I think most of us are back to about 80-90% of our practices or to this thing. But the corneal grafting is still, I think, lacking, and maybe it would be picking up soon. So that's what I will wish to add.
Thanks, Dr. Mahipal. Dr. Rajesh, anything else to add?
I think also we need to look at with the lamellar surgery, tissue utilization can be improved. You can use a single tissue for doing a DMEC and DALC as well. So that's again optimal utilization of tissue when your collection is less. Maybe even the DSEC lenticule, when the anterior cap which is there, instead of discarding it, it can be preserved and it can be further used. So I think we have to look at ways and means of optimizing tissue utilization at the eye bank when the collection is lower, especially for dealing with infections, perforations, where if because of lack of donor tissue, sometimes the management becomes quite difficult.
Any other important question was left unasked? Panelists?
Just wanted to ask Praveen, any modification do you do when you do a PRK on a grafted eye in terms of using intraoperative mitomycin C or postoperative duration of topical steroids? Because often it's seen that these eyes, maybe sometimes the tendency for haze formation is a little more compared to virgin eyes.
Yeah, I do a specular and then I do a 2-minute exposure of mitomycin C on these eyes, irrespective of the amount of ablation. So that seems to work pretty well.
Dr. Any thoughts? Just this thing. How would smile work on post-PK astigmatism?
No, that opens up a whole new.
Maybe you could try something about it. I don't know.
But anyway, the major challenge is the astigmatism in these cornea. So a smile, I don't think really corrects to high astigmatism.
But sometimes
up to 6, but the only thing is that even if there is a residual refractive error or myopia when an astigmatism, I was just wondering how it will work.
So I think I'll conclude then. It's been an amazing webinar with real experts on the expert panel who gave the inputs, and we seem to have discussed all the relevant aspects with leading line of speakers too. Special thanks to one and all of you in this audience. My thanks to my co-moderator, Dr. Rajesh Fogla, who should have actually been one of the speakers and we could have gained even more from him. Paucity of time, there was only this many questions we could ask. My thanks to my very able ARC team, and it's so nice to see them here till the end of the show because many of us are not too connected to cornea. My thanks to AIOS admin led by Mr. Kripal and his entire team. Mr. Sunil, who actually is the administrator of the webinars and has been doing a great job over this year. Sai and Manjula from Numerotech for steering us through our ARC works. My immense thanks is due to the Entode group and Mr. Nikhil, who have been our major sponsors, rather main only sponsor for all the educative activities of ARC. My deep felt thanks to them. And my thanks are due to our dear attendees. There have been quite a few of them in spite of the festival time. And thanks for all your support, which helps us scale newer heights. Thank you, one and all of you. Thanks a lot.
Thank you, Rachitra.
Thank you.
Thank you for organizing this excellent thing.
Great speakers.
Thank you.
Thank you.
Thank you.
And a happy Pongal and happy Sankranti to all of you.
And a happy Lodi.
Happy Lodi. How did I dare to miss that?